Ladies and gentlemen, it gives me a great pleasure to welcome all of you in this series of webinars I'm organizing as second vice president of the World Federation of Surgical Societies, the WFNS, in collaboration with the Continental Association of African Neurosurgical Societies, the CANS, and the Egyptian Society of Neurological Surgeons, the ESNS. Glad to tell you that we already organized 49 webinars. 15 out of them were educational WFNS symposium. Today, it's webinar number 50. I'm honored that this webinar is organized in collaboration with Professor Mehmet Zelili. He's the chairman of the Spine Committee of the World Federation of Neurosurgical Societies. He's honorary president of the Middle East Spine Society, and he is chief in the Department of Neurosurgery, Edge University, Izmir, Turkey. First of all, I would like to welcome our keynote speakers. I will go by the order by which they speak. Professor Kwaishi Siro, he is chairman at the Department of Orthopedics, Takushima University, Japan. And he's chairman of the board of the Japanese Association of Endoscopic Spine Surgery. Professor Marisa Alejandra, she is affiliated to the Department of Neurosurgery, University of Buenos Aires School of Medicine, Argentina. And she is president of the Argentinian Association of Minimally Invasive and Endoscopic Spine Surgery. Professor Javier Olvera, he is affiliated to the Department of Neurosurgery, Hospital Star Medica, Anahuac University, Querétaro, Mexico. Professor Hua Jin is professor at the Department of Neurosurgery, Medrix Hospital, South Korea. Professor Rodolfo Pere, he's chairman at the Department of Neurosurgery, San Jose Hospital, Celaya, Mexico. Professor Malcolm Pistonji, he is affiliated to the Department of Orthopedics, Mahatma Gandhi Mission University, Navi Mumbai, India. Professor Zhu Wanbing, he is affiliated to the Department of Orthopedics, Dalian Central Hospital, Dalian School of Medicine University, Dalian, China. Professor Bon Zhang, he is affiliated to the Department of Orthopedics, Jinju Bon Hospital, South Korea. Professor Zhang Wai, he is in the Department of Orthopedics, Hangzhou Hospital of Traditional Chinese Medicine, Hangzhou, China. And finally, Professor Mehmet Zelili. He is chief at the Department of Neurosurgery, Edge University, Izmir, Turkey. Would you forgive me if I was pronouncing the names or the names of the centers not too much correct? I would like to thank all our speakers for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience, especially at this tumultuous period of the global pandemic, is well appreciated. Our program consists of 2 sessions. Each session is 1.5 hours. And in each session, we will have 5 speakers. And we will have discussion at the end of this session for about 10 minutes. All the topics are interesting. This is the second session. And this webinar is about minimally invasive lumbar spine surgery. It's actually a collaboration between 2 specialties, the neurosurgery and orthopedics. Actually, it's very important to have knowledge exchange between 2 important specialties. Both of them are doing the spine surgery. Until yesterday, we have registrants over Zoom, 315 registrants, as you can see from this screen. We are doing live stream over the Facebook page of the CANS, and you can see this link, and over the YouTube channel of the Egyptian Society of Neurosurgery. And we are also doing a broad live cast over the Neurosurgical TV of John Bennett. In this occasion, I would like to thank John Bennett for the very great job he's doing in order to promote our webinars and to promote neurosurgery globally. All attendees, we are glad to get all your questions and comments. It will be monitored through the chat panel or the Q&A. This is the type of certificates we are offering. You can print your certificate electronically through this link. The username will be the email by which you register to the webinar, and this is the password you can see over the screen. Please just allow a few weeks for our organizing team in order to upload emails to the system. Important to announce that next Friday we don't have a webinar because as a type of coordination, there is another event which is organized by another colleague in Kenya. And so Friday, 13 August, we will cancel our webinar, and webinar 51 is going to take place on Friday, 20 August, after 2 weeks at the same regular time from 2 to 5 p.m. Egypt time. And this will be in collaboration with the Neurorehabilitation and Constructive Neurosurgery Committee of the World Federation of Neurosurgical Societies. The chairman is my friend, Professor Virendra Diosinha. And we will have 8 eminent speakers at that event. Important to tell you that the Pan-Arab Journal of Neurosurgery already relaunched, and I'm happy to relaunch this journal again after being locked for 10 years. We published the first issue June 2021, and the publication is free, and I'm honored to be the editor-in-chief of this journal. All your submissions are welcome through the address seen over the screen. Another important announcement that I'm organizing the Third Demands Congress. This will take place in Egypt, 27 to 30 October 2022. It was postponed because of the COVID-19 pandemic. I will be president of this Congress, and the president of the Mediterranean Association of Neurological Surgeons is Professor Alberto De Litala. All of you are invited, and I'm sure it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much for attention. Now I give the word to my great friend, Professor Mehmet Zelili, Chairman of the Spine Committee of the World Federation of Neurosurgical Societies, to say his welcome note. I can also see Professor Mahmoud Qorashi is President of the Continental Association of African Neurosurgical Societies. Maybe he's interested to give a welcome talk, of course, also after Professor Mehmet Zelili. Thank you very much.
Thank you, Professor Nasser El-Ghandour. It is my privilege to be a part of this interesting, very interesting symposia, a virtual symposia. It is really a combination of orthopedic and neurosurgical speakers, and very challenging topics. As you know, we are getting forced by patients to make more and more MIS surgeries, minimal invasive spine surgeries, but it has some disadvantages and advantages. So we will see some new techniques, some very discussive techniques in that 3 hours webinar. I thank all the speakers from all over the world: China, India, Argentina, Mexico, Japan, and many places. It will be a very, very good meeting, I'm sure. Thank you. Mahmoud Qureshi, do you wish to say something?
Yes, thank you very much, Mehmet. It's always a pleasure to see you, whether it is live or virtually. And I see many of my friends. On behalf of the Continental Association of African Neurosurgical Societies, I wish to thank you and for putting together such an array of stars from across the globe, all the way from west to east, to share their knowledge and skills. And on behalf of all member societies of the Continental Association, all our young neurosurgeons and orthopedic surgeons who will have joined this webinar, and our trainees, I really wish to thank you from the bottom of my heart for taking your time. And Nasser, once again, you continue to move the envelope on behalf of the Continental Association of African Neurosurgical Societies and have placed the continent as a leading group that is involved in the teaching and education of young colleagues in our specialties. So thank you very much, and I wish you very great and successful deliberations. Thanks once again.
You must unmute, Nasser.
I'm sorry about that. I'd like to thank you very much, Professor Mahmoud Qureshi, President of the Continental Association of African Neurosurgical Societies, for these kind words. Now we start the scientific sessions. The moderator of these sessions will be Professor Mehmet Zalili and myself. Thank you very much. Professor Mehmet, would you introduce our first speaker, please?
Yeah. I want to ask Dr. Koichi Sairio from Japan to give a talk on full endoscopic transcumbin lumbar interbody fusion. Yes.
Can I start now?
Yes, please.
Okay. Thank you for this invitation. My title is Full Endoscopic Transcumbin Lumbar Interbody Fusion. I call KDIF. So my name is Koichi Sairio from Japan. This is my COI. What is KDIF? I think this is a full endoscopic transcumbin lumbar interbody fusion. This technique is under full endoscopic guidance. And also cage insertion is through the cumbin triangle. So I named KDIF. There are two great mentors, professors, of course, Professor Kambin and Professor Hijikata. They invented this approach. Sometimes this technique is misunderstood that TLIF, but KLIF and TLIF is totally different. KLIF, I always preserve the facet joint. So this cumbin triangle, I insert the cage. But the TLIF, this is a corridor after total ectomy. So KLIF and TLIF is totally different. And I invented the full endoscopic KLIF system a couple of years ago. Please look at the yellow arrow. Just 12 millimeter skin incision, we can insert a cage through the cumbin trial safely. I can show you my technique. Most of the case is spondylolisthesis. So first of all, I inserted the PPS and reduce. Reduction is very important to make the cumbin triangle normally and larger. Look at this. I now inserted the cannula just outside of the facet joint. So superior articular process. Then I started the foraminoplasty. I drilled out superior articular process to make cumbin triangle wider and wider. Look at this. I measuring the distance of the opened disc surface. This surface should be 12 millimeter. 12 millimeter means 4 drill heads. 1 drill head are 3 millimeter. So I always make a 12 millimeter surface. Then I insert a safe guide. Safe guide, you can see the ball shaped tip, and it can prevent the accidental insertion into the abdomen. Then we can insert the cannula. The cannula is 8 millimeter by 10 millimeter. So look at this. I'm inserting Now I'm just surface of the disc of the cumbin triangle. I'm inserting a spacer 8 times 10. See here. So this spacer is 8 times 10. So I rotate it 90 degrees. So the disc distance going up to 10. Most important point is exiting nerve root injury prevention. So always I'm doing neuro monitoring. So I'm always listening at the free run monitoring. If warning sound says the sounds, this means I'm touching the existing nerve. Then we need a more foraminoplasty. Then I insert the open cannula. Then using a curette, we can curette the inside of the disc. You can see here the open square cannula. It is preventing existing nerve. Then bone graft. Special made funnel, I'm inserted the bone. You can use allograft or autograft. Usually I'm taking autograft from pelvis. See here, look at this existing nerve and open cannula. Always preserving the nerve root injury like this. Then I like to use expandable case. So this expandable case is sliding inside the disc, no nerve root injury. See here, this is expanding from 7 millimeter to 9, 10, yeah, going up. This is one example, 84 years old female, low back pain and leg pain, spondylolisthesis posteriorly, and she underwent a laminectomy 5 years ago. And the leg pain is coming from foraminal stenosis at L3, L4. For this case, before you can see here a complete collapse of L3, 4 disc space, but after I inserted the cannula, 8 millimeter cannula, the disc space going up, then opens cannula, 10 millimeter. Okay, now I'm inserting the cage and also expand it. See here, cage insertion device and open cannula is removed. I can show you another example. 57 years old female, grade 1 spondylolisthesis. However, in flexion position, it's going to grade 2 spondy. However, her symptom is just intermittent claudication. We couldn't walk more than 100 millimeter, but at rest, no symptom. So we assumed just fusion is okay. So I selected indirect decompression and fusion. See here, during surgery, I did myelography. You can see here, complete stop before surgery, before insertion of the cage. And if I insert the 8 millimeter cannula, the myelography is coming down, and 10 millimeter and cage insertion finally. Finally, myelographic dye is coming cautery space. See here, during surgery, myelography shows complete reduction, complete stop. But after surgery, it dye going down. Similarly, this is a 57 years old male. His symptom is also intermittent claudication only. At rest, no symptoms. So I decided to do indirect decompression with full endoscopic K-lift surgery. During surgery, I did myelography. So after surgery, the dye comes down and completely indirect decompression is performed. Yeah, totally 28 cases so far, but actually I did 2 days ago. So now I did totally 29 cases. And earlier 13 cases, I used Professor Nagahama's PET system. But after May 2020, I used my system. So totally 29. And clinical outcome is excellent and good. And only 70% shows a complication. It's existing nerve root irritation. Just sensory, some strange feeling, no muscle weakness. So I said, no nerve root injury. It's an irritation. Okay, thank you so much. I'm holding a World Congress of minimally invasive spine surgery and technique this year in Tokyo, Japan. After pandemic is over, please come to Tokyo. I want to welcome you, but maybe it's very difficult. So please attend this meeting online. And my place is not Tokyo, my place is Tokushima. Tokushima is a very old local town. A lot of natures, a lot of oceans, very nice place. So far I'm having international fellows, and after COVID-19 from Egypt, 2 doctors are coming, and India, Jordan, Pakistan, Philippines, many fellows are coming. So if you are interested in my technique, please contact me and please come to Japan, Tokushima. And this is the final take-home message. And transforaminal full endoscopic surgery is a cutting edge, and it can make a future gold standard. Thank you so much.
Thank you, really. It was great talk, and I thank you for being in time in your talk. Now I call the second speaker, Dr. Marisa Alejandro Perez Solis from Argentina, for giving a talk on transsacral epidural laser decompression.
Thank you for the invitation. It's
You
a
can share the
beautiful
screen.
presentation, Professor Koichi. Argentina.
Good.
This is our university, the place where we have our endoscopic center. Our presentation is a transsacral epiduroscopic laser decompression, the management of lumbar extrusions through transsacral approach. Endoscopy has become a successful tool in the management of these herniations. We propose the use of an endoscopic approach through transsacral epiduroscopy to treat lumbar extrusions. Percutaneous epidural neuroplasty is a therapy for spinal diseases. Although it was originally developed to treat postoperative adhesions, pen has also been used for targeted drug delivery and neural decompression. Additionally, the procedure has shown good clinical outcomes as treatment for lumbar disc herniations when compared to physiotherapy. However, the disadvantage of the pen procedure was that it couldn't decompress the herniated disc. So we proposed a percutaneous lumbar laser ablation as an alternative solution to address this problem. The first clinical percutaneous lumbar laser disc decompression was reported in Europe by Choi and colleagues in 1986. This is part of the old instruments that were used, store cytoscope. In 2001, we founded the Neuroendoscopic Anatomy Center in the University of Buenos Aires. These were one of the many works, studios we presented. In 2001, we had one in a neurosurgical magazine, where we reached these conclusions. The direct visualization, we could get with epiduroscopy, the direct visualization of pedicles, the visualization of nerve root exit, the identification of lesions, fibrosis, tumors, and causes of radicular pain, and we could also perform transpedicular fixation. In percutaneous lumbar laser ablation, laser energy is delivered to the herniated lumbar disc through a thin optical fibers that we could see in the pictures. The absorption of the applied laser energy vaporizes the water content of the nucleus pulposus, changing its protein structure. Here we see the OR. We propose the use of endoscopic approach with transsacral epiduroscopy to treat lumbar extrusions. In our cases, all patients had leg pain that was refractory to conservative management for more than 6 weeks. Each patient also had a single level HLD that was checked by MRI. You can see here the exclusion criteria. The objective of our study was to prove endoscopic transsacral approach is a safe, minimal invasive approach that can be performed on ambulatory basis with minimal complications. We performed it on 557 patients from August 2010 to December 2020. Patients were evaluated by visual analogical scale. We used flexible fiber optic scope with a field of 180 grades and integrated fiber optical illumination. You can see here are materials, the endoscope. One of them was an E-Dolphin, a spiroscopy set with a 2E needle, our laser probe, and the radioscope. Steps of the procedure are first the identification of sacral hiatus, infiltration with silocaine, and then we introduce a 20-gauge needle under fluoroscopic guidance. It's a very small incision. We then puncture the ligament with a 2E needle under fluoroscopic guidance, and you can see there in the picture. Then we insert the trocar and the lathe. You can see the video over there. We enter the endoscope with permanent infusion of saline solution in a very slowly manner. We can see here the catheter in the paracentral area of the disc by radioscopy. So we check that everything is in correct place. Here the catheter is shown in the ventral area of the epidural space. You can see it in radioscopy. There's no need for abundant irrigation to obtain high quality images. The recommended duration of the procedure is 60 minutes. There can be some videos here, the entrance to the channel, to the spinal canal. The adhesions, the white adhesions over there. We're entering the channel. You can see the surgical OR here. Some pictures of extrusion as they are seen in endoscopy. We will show you some videos now. Here you can see the red light of the laser working on adhesions, breaking adhesions down to liberate the nerve root. We also use a balloon to dilate, open the channel. There you can see finally the nerve root that is freed completely.
The video is not showing.
No está pasando el video.
No sé.
No. Here we go, and that is a nerve root freed already after using the laser that was seen on the video. The laser and a balloon and the freed root.
The video is not showing.
Al final lo mostramos.
We will show it in the end. The results were patients were evaluated by visual analogic scale pre and post-op, and there was an improvement of being 80% of their previous pain status with complete remission of symptoms at 6 months follow-up. The transtracheal epiduroscopy can be used for high-grade centrally down migrated lumbar disc herniation. There you can see the catheter, the spinal needle, and the epiduroscope placement in APL lateral view. Epiduroscopic assisted transforaminal PERL is a good alternative for difficult PERL when there is high-grade disc migrations and chances of missing the fragments are high. So we combine both procedures, epiduroscopy and PELD, to reach all the disc fragments. Patients can be discharged in the same day. Well, you can see the OR and her team. There are no serious complications related to the procedure. The procedure was performed on the OR and the patient discharged after 2 hours. Our conclusion is that the endoscopic management of lumbar extrusions through transsacral approach is safe, successful, minimal invasive procedure to treat lumbar extrusions. We will try to show you some videos. We don't know what's going on with the videos. Well, you can see some beauties of Argentina. Can you see the videos now?
No, unfortunately not.
No,
No.
not that.
Estoy en la... Bueno, vamos a compartir. Estoy dentro de Zoom. No.
Can you see them now?
No.
Oh,
No.
te van a avisar. Sí.
No. Sorry.
Can you see the video?
No.
I don't know. Sorry.
We sorry, don't know what's happening with the videos.
Okay. Then we can switch to the other speaker because video is not there. If you can make it ready later, we can show it. Okay.
Okay. Thank you.
I thank you really. Now I want to invite the third speaker of our first panel. This will be Dr. Javier Cuilo Olvera from Mexico. He will tell us the unilateral biportal endoscopic transforaminal lumbar interbody fusion.
Thank you very much, Professor Mehmet. Can you see my screen?
Yes.
Okay, thank you. I appreciate your kind invitation, and I'm so happy to participate again in these kind of sessions. I'm Dr. Javier Quillo, so I am speak about endoscopy, and through my group, my entire group, there are also another spinal surgeons in my group. They are my family also. So today I will talk about, I want to share with you an overview of UVE TLIF. This very well-known concept is that determines the biportal endoscopy to perform fusions. So we have learning objectives. For example, I want to share with you what cases are suitable for TLIF, for example, what is the indications and what are the specific patients to perform TLIF. Also, the surgeons need to familiarize with the concept of unilateral biportal endoscopy because the DAB is different to transcamin approach, to transcamin uniportal approach, to uniportal endoscopy, or to MIS TLIP. So there are doubts that we have to respond in this talk. So also, why should I change my tube for the endoscope? If I am a spine surgeon and I am comfortable with using minimally invasive techniques to tubular or to Caspar or any other mini open or any other MIS technique, why I should change my techniques for the endoscopy, especially for biportal endoscopy. We want to review also the stepwise technique, and finally limitations and beyond the horizon regarding the biportal endoscopy. So what are the indications for TLIF? We know the TLIF has advantages and some limitations, but the indications are regarding the goals of the TLIF. You know, direct decompression, indirect decompression, achieve segmental lordosis, or how can I fix the spine? There are terms that we can achieve with the TLIF. So mono or multi-level instability with sagittal imbalance, we can obtain acceptable comparable fusion rate with other fusion techniques and achieve proper segmental lordosis, but it depends of the interbody device also, the location of the interbody device when we delivered in the intervertebral space, and the features regarding the interbody device. Right now in the market, we have a lot of interbody devices, and the last technology offers to us expandable cages like Professor Koichi Sairo showed. Also, we can treat degenerative or isthmic spondylolisthesis, but my advice is to lower grade the EC reduction, because we have high grade spondylolisthesis that can be suitable for other fusion techniques. Also, we can treat severe degenerative disc disease with lower back pain, but anterior column support via a posterior approach release and treat, we can obtain this advantage, but we have another technique that can resolve this point specifically better than TLIF. We can treat severe spinal stenosis or foraminal stenosis with TLIF because we can reach the target, the neural element, and decompress it. We can obtain enough decompression through this technique, but indirect decompression is not the major indication and the major advantage regarding TLIF. So the TLIF aims to, we need to understand the goals and then change and then make a change in the technique to evolve. So the direct decompression, indirect decompression, segmental lordosis, stabilization, and fusion are especially important during TLIF technique. But the surgeon needs to familiarize with the concept of unilateral biportal endoscopy. What is this concept? It's using two ports specifically for the endoscope and for the surgical tools. Then we create a space. We create a space, and with the hydrostatic pressure of the continuous saline irrigation in a space called epiperiostral space above of the bone elements and below of the muscles, and then we reach the target point. This approach is specifically for transforaminal lumbar interbody fusion to the unilateral biportal endoscopy. The approach is called paraspinal. So we use a plan between the longissimus muscle and we can reach medially the foraminal area, and we can reach laterally the supraarticular process. So is there any difference between minimal invasive techniques and biportal endoscopy? Yeah, there are so many differences. And the most important differences between, for example, biportal endoscopy and open surgery is obviously the invasiveness. In the endoscopic techniques, we use especially areas. For example, in biportal paramedian approaches, we use an area medial to the multifidus muscle, and we can reach the spinolaminar junction. In the paraspinal approach, we use the space between longissimus and iliocrustalis muscles, and we can reach the foramen and reach the facet joint and perform the very big decompression without damage or a minimal damage compared with open surgery or tubular surgery for the muscles. Also, the costs are very important, especially in Latin America and Mexico. Maybe uniportal endoscopy is expensive compared with biportal endoscopy, but biportal endoscopy is very similar to open surgery because we have in all the hospitals general instruments, for example, arthroscope or general surgical tools. So based on what should I try UVE, for example, if we compare specifically UVE TLIF compared with minimum basic TLIF, we have pros, as I told you. Especially in this technique, we can use epidural or conscious sedation depending on our learning curve. We obtain less trauma to paraspinal muscles. Also, we can obtain direct visualization of the neural structures through the endoscope, endoscopic visualization of the end plate preparation. This is very important because one of the features of TLIF is prepare very good the intervertebral space to obtain a very good fusion rate. So if we can achieve this goal through the endoscope, it's wonderful. Also, ipsilateral, central, and extended contralateral direct decompression can be achieved by biportal endoscopy, depending on our approach. If we perform our approach with a steeper angle, we can make decompression ipsilaterally. For example, only facet joint. But if we perform or angle attack to the spine and we obtain a shallower angle, we can cross the midline and perform bilateral decompression. Also, less postoperative pain and decrease of opioid consumption, and also treat high BMI patients are very suitable for this biportal technique. We can observe during all the surgery the interbody device and the delivery into the intervertebral space, and this is safety for the traversing nerve and exiting nerves. And also, we use general surgical tools. All the spinal surgeons are familiarized with these surgical tools, and we can obtain fewer durotomies compared with open surgery or tubular surgery because all the surgery we can observe directly the neural elements, and then we can screw in the spine to the same incisions, avoiding more damage to the muscles. But we have cons. The experience is required in this technique. We require also especially training and a steeper learning curve in some cases. For example, in doctors that they are not familiarized with arthroscopy, or neurosurgeons like me, for example. In the first surgeries, we can reach longer operative times that is not good for the patient, for example, because after surgery, even the surgery was wonderful and perfect, the patient had pain in the muscles because the position during all the surgery. And we require more structured long-term data regarding outcomes, lordosis, and fusion rates. What are the indications of UVE TLIF? The same comparing with minimally invasive transforaminal interbody fusion. Failed conservative measures, for example, between 6 to 8 weeks, mono or two-level low-grade spondy with instability, severe degenerative diseases with lower back pain, radiculopathy, unilateral or bilateral or clinical from central spine stenosis, and contraindications. Right now, our technology is not good to perform multi-level high-grade spondy or very severe degenerative lumbar spinal disease, because we have more techniques, and that techniques are suitable for this kind of diseases, severe diseases. For example, severe deformity. If we have planning for better alignment or stabilization, opting for other lumbar interbody fusion technique. If the surgeon, if the surgeons they don't have experience with the biportal endoscopy, maybe it's not the best option to treat or try. How can I reach the disc? For example, Last year, we had only two techniques to reach the disc through biportal endoscopy. For example, transcambion and posterolateral. But this year, Professor Un and Professor Ho, they published the modification of posterolateral biportal endoscopy that they call XTLIF, of extreme lateral transforaminal lumbar interbody fusion. The concept is to take advantage of all the trapezoid area of the cambium triangle. That makes sense if you remove all the facet joint, and then you take advantage of all the length of the disc below and before of the traversing nerve. We perform also, we publish the steps for the biportal endoscopy with patients in Mexico, my group and I. And the stepwise technique, we require surgical instruments, but general instruments. We use radiofrequency probe, shavers, drills, 30-degree arthroscope, general surgical tools, for example, dilators, curettes, muscle detractors, retractors, dissectors, Carrison punches, or pituitary rongeurs. I plan the incisions through a perpendicular skin incision. This is my technique, different maybe from Asia, but I prefer use these incisions because at the end of the procedure, it's very simple to put the screws through the same incisions that you deliver education, perform all the procedure. Perpendicular skin incisions are planning before the surgery with the radiological studies. Then triangulate the tubes, the dilators. This is very important because this is the first step and the 50% of the surgery. If you perform a very good triangular approach doesn't mean that you perform a perfect triangle. It's join the tips, the vectors in your target point, and then you can delay the muscles and put the endoscope and put the other side, your working channel, and perform perfectly your procedure. Then when you perform this first step, you can reach the facet joint. For example, we use a more elegant technique because we adapt the navigation to the biportal transforaminal interbody fusion. But the similar steps are commonly used in all the technique. You reach the facet joint and then you perform the facetectomy. This intraoperative image is showing how you can see after drilling the supraarticular process and the periarticular process and the cleft, the space between both articular process, the synovium. This is a very good landmark to orient the surgeon and continue with the technique. Then after perform the complete facetectomy, you reach the ligamentum flavum and you can start with over the top in direct decompression of the neural elements. After flavectomy, you can reach the neural elements, and this is the first goal of the TLIF. The direct decompression. In this intraoperative view, you can observe how we can decompress the traversing nerve, the exiting nerve, and all the disc and the thecal sac. In this schematic example, we put in yellow the cambium area. Then the discectomy is performed through the same and similar way than open and miscular technique with the TLIF. We use pituitary rongeur, different curettes, shavers, etc. But the main goal is prepare perfectly the end plates because this ensure after surgery a very good fusion rate. So this is the goal. After that, we put the graft. We use autologous graft mixed with DBM or some BMP, depend on the patient and depending on the case. And then after that, we put the cage. And the cage is burning through direct endoscopic visualization to take care of the traversing nerve and the neural elements, for example, the exiting nerve. We put very big cages, for example, 13 millimeters, 14 millimeters, depending on the case. Why? Because we release the lumbar spine with the facetectomy or the annular release. After that, we put the screws in a percutaneous way. This is a case example of a patient with spondy grade 2, 56-year-old female with 5 months of radicular pain and weakness in both legs, symptoms of central spinal stenosis and radicular pain, 1 month of severe lower back pain with no with failure to conservative measures, and she had bilateral weakness on ankle dorsiflexion and conservative treatment for 8 weeks with no improvement in her symptoms. You can observe in the X-rays this spondy grade 2 instability in L4-L5, and the diagnosis was unstable L4-L5 ischemic spondy grade 2 with lumbar spinal stenosis. You can observe that anteriorly to the vertebral body, we had the vessels, the major vessels, and high rising psoas muscle. So maybe PLIF or TLIF open, maybe there are good options for other surgeons, but anterior or lateral or antepsoas approaches are not suitable for this patient. We choose the L4-L5 UV TLIF. This is the intraoperative video. You can observe the supraarticular process. This is the lateral aspect of superior articular process. Then we perform the facetectomy, complete facetectomy, and we decompress directly the nerves. This is traversing nerve. This is the cecal sac. Here is the exiting nerve, and this is the DC space. And after that, we perform the discectomy. We use different surgical tools, and we prepare good the intervertebral space, the end plates. We use different proofs before delivery the cage. After that, we put the graft, and finally, we put the cage through direct visualization and taking advantage of all the length of this space prepared before the delivery. This is the pre-op versus post-op views. This is the X-ray. We reduce the spondy, and this is the post-operative immediately MRI with very good central decompression and very good lateral decompression, and the patient improves very well after surgery immediately. Limitations and beyond the horizon, more scientific data are required and more methodological data are required. Skill and experience are required. This is a new technique, so maybe with the time they're going to popularize in the world, not just in Asia or some parts of the world. This is a minimal invasive TLIF, so this is we can obtain advantages similar to other minimal invasive techniques. The future is the endoscopy for fusion. The industry, we need more devices, more evolved in the industry, and the technique maybe with the time becomes popular. As a conclusion, the main related procedure advantages are independence of the scope and instrument control and greater degree of freedom for moving the instruments in the surgical field. The UV TLIF reach segmental stabilization in the lumbar spine. Direct decompression with endoscopic vision is a worthy advantage. All these benefits have been observed in UV TLIF. Thank you very much.
Thank you, Dr. Javier. Yeah, really very nice talk. I think we have to come to the last speaker. This is Dr. Huwajin Oym. He will tell us endoscopic extreme TLIF for large olive cage.
Mehmet, we have another speaker. We have still 2 speakers in the first session. After we have, I think.
Yeah, we have one more.
Rodolfo. Yes. Okay.
So can you see my screen?
No. Dr. Huwajin Oym is the.
Yeah. So can you see my screen?
Yes. No, not yet. Sorry. You must share it.
Okay. Can you see?
Yes.
Okay. So can you see my screen?
Yes. Yes.
Okay. Hi, everybody. Nice to meet you. I'm Dr. Jin-Hao from South Korea. Actually, I'm working in the Burj Royal Hospital in Abu Dhabi, UAE. And it's my honor to participate in this brilliant webinar. My topic is endoscopic extreme TLIP for large cage. This is my disclosure. And is it possible putting a large oblique cage under endothelip procedure? I will show you. There are various surgical approaches for lumbar antibody fusion, as you know. PLIP, TLIP, neck slip, and OLIP and ALIP. The goals of spine fusion surgery, I think, is number one is a decompression of pathology region, and we have to do bone-to-bone fusion, and if possible, we have to restore the spine balance. For better spine fusion, precise and gentle end preparation is necessary, and large interbody spacer will be better. And cage position is also very important. So we can use bone materials, autobone and DBM on BMP or IPECTOR. Whenever I'm doing an endoscopic fusion surgery, I feel this kind of limitations. The fusion bed is too small, and I cannot correct lordosis enough. Okay. Sometimes I cannot do complete end preparation. So I think for good coronary sagittal balance, and cage size and cage position is very important. So I usually recommend PI-LL mismatch should be less than 9 degrees. Let's see the cage size. I think the bigger cage would be better. In case of TLIP cage, the width is 11 and 13, and length is 28 and 32. Now some factory produces 38 millimeter, but X-Lib and OLI cage, the width is already 18 and 20 and 22, and length is 40, 45, and 50. So in this picture, you can see the difference. This is PLIP cage, TLIP cage, and OLI cage is bigger. So prevention for subsidence, the bigger cage would be better. Cage position, according to the Alexander Labussy, unfortunately, the center of the end plate is the weakest part. So in this picture, you can see the cage is well positioned, but in the center of end plate, and the size is too small. And so I use the banana cage, and this is OLI cage. You can see the difference. So I think the good cage position should be in the coronary view. Cage length should be between pedicle and pedicle. And in the lateral view, the center of cage should be the anterior to the center of the body. For better fusion and correction, among this fusion surgery, I think the OLIP and X-Lip would be better. But OLIP surgery have some disadvantages. We always have to worry about vascular injury and sympathetic chain injury, urinary tract and peritoneal injury. And this technique is not so easy technique for ordinary spine surgeons, especially in the level of L5 S1 level. So only we can do is indirect posterior decompression. So, and we cannot use the autobone. So for posterior decompression, we need to change your position. But recently, some surgeons can do it in the lateral position. So I think, I thought under TLIP procedure, because this procedure is familiar to spine surgeon, as if you can put a large cage, such as OLIP and X-Lip cage, into the interbody space would be better procedure. So I reviewed the Cambridge triangle. According to the Reed article, cadaveric analysis of Cambridge triangle, the base L23 level 13, L34 level 17, L45 level 18. Unfortunately, there is no data for L5SN area. But as you see, L34, L45 level, we can use large only cage. So I have to make a X-tip corridor. So I removed facet joint completely, and so I extended Cambly triangle. I call it LEK, length of extent triangle. So the L34 level, the LEK is over 17, L45 level 18, L5SN level. Fortunately, the facet, the width is very large, so we can put the 18 and 20, 22 widths only an X-ray cage into the interbody space. Always, this is example of preoperative measurement. I always check the LEK preoperatively in the MRI. So L45 level, the average is 18 to 21 millimeter. L5SN level, the average is 19 to 22 millimeter. So this is the picture of endoscopic view. And this is LEK, already 18, or this is 20 millimeter. So we can use only an X-ray cage. So I made X-TLIP surgery with endoscopic TLIP surgery, and I have to do total prostatectomy, and I can use a large cage, same as the size, the same as only cage, and anterior and transverse line cage is necessary. And this is X-TLIP procedure is between the TLIP and X-TLIP, between the TLIP and X-TLIP. Okay, X-TLIP. So indication of X-TLIP is the same as TLIP surgery. I'll show the cases. The 65-year-old male patient and lower back pain with left leg radiating pain. Already he did 6 months ago endoscopic decompressive surgery, but there is no improvement. In the preoperative MRI showed we can see the lateral recess stenosis and L5SN level foraminal stenosis. And this is the picture of endoscopic view. This endoscope preparation is good, and we can get enough amount of autobone. The video. This is transforaminal approach. This is L5 exiting nerve, and this is medial side. This is transversing the root is here. Already I removed facet joint completely. And we can use ordinary spine surgery instrument. This is Kelson Ranger. The procedure is the same as TLIP surgery. I put a shaver into the L5SN level. Gently end preparation. And we can put the large only cage into the L5SN level without nerve root damage. This is actually the only cage. Okay. This is post-operative X-ray. The pedicle lies from pedicle to the cage lies from pedicle to pedicle, and the lateral view have a good rhodotic curvature. Post-operative MRI, cage position is good, and the decompression is well. Next case is 75-year-old female patient and low back pain with left radiating pain, diagnosed as spondylolisthesis L4-5, preoperative MRI and postoperative MRI, well decompressed state, and the cage position is good. This is paramedian approach. This is L4, L5, lateral and medial. The procedure is the same as TLIP surgery. Laminectomy, and we can do prostatectomy. The procedure is just the same. After total prostatectomy, we can see the L4 exiting nerve, and this is transversing nerve root. And we can put the shaver into the L4-5 discal space. After complete end preparation and trial, we can try. Okay. And under I usually already use a cage guide. This is only cage. Through the cage guide, I put the only cage into the L4-5 discal space. This is, I think, this is, I can tell the posterior orthogonal maneuver. Either to lie the cage anteriorly and transversely. So this is nerve. Okay. And next case is a very interesting case. Already this patient have L4-5 level schwannoma, and also she had spondylolisthesis. So I have to do the remove schwannoma under microscopic control, and then I put the X-ray cage into the L4-5 level. This is a picture of a microscopic decompression. And next case is 76-year-old female patient and foraminal stenosis L2-3 and lumbar stenosis L3-4. And at 2-3 level, the operative corridor is very small, so I put a Tilly cage, and L3-4 level, fortunately, I can use the only cage. So this is post-operative MRI film, very decompressed state, and the cage position is good. So I compared the lordosis pre and post-operatively, and almost all cases we can get a better lordotic curvature. But in this patient, we did X-Tele4-5 level, and we put a interspinous device 3-4 level. So the lordosis is not good. So surgical tips, I think I usually recommend for to get a good lordotic curvature, unilateral swab to osteotomy, and anterior transverse line of large cage, and if possible, anterior distraction and posterior constriction. So I always try to make a PILA mismatch less than the 90 degree. But the advantages of X-Lab is we can do direct decompression, and reduction is possible, and we can get a coronary side balance, a proper high fusion rate and low subcisions rate. So we can avoid vital organ injury. So also spine surgeon friendly procedure, no need for backup vascular surgeon. Complications may be same as those of TLIP surgery. Disadvantages of X-Lab is technically demanding. And we always worry about in the running stages, the root injury. Minimal, but it is also posterior approach. A rare contraindication is I don't recommend upper levels above 2-3 level. And if the small LEK, less than the 15 millimeter, I don't recommend to. So we can do 3 levels, but it takes too long time. So I recommend only 2 levels. So if you need over 15 degree lordosis correction, I don't recommend. We have to do open surgery. At present, in Korea since 2019, more than 10 hospitals in Korea, already we had over 200 cases. So 2021, February 19th, Dr. Ho and I published the first EXTLIP article, and you can use reference this article. So EXTLIP is possible. So conclusion. So EXTLIP procedure provides large interbody fusion bed and spacer compared to TLIP surgery, and bigger cages would be better, but further long-term study is required. Thank you very much. Thank you for your attention.
Thank you, really. It was a very fascinating talk, really. I thank you a lot. And I will invite the last speaker of this session. This will be Dr. Rodolfo Guerrera Perez from Mexico, lumbar degenerative spine resolved by biportal endoscopy. Yes, please share your screen.
Thank you very much for the invitation. Hi, everybody. I'm Dr. Guerrero from Mexico. Thank you, Dr. Nassar. Thank you, Teplinsky and Endovision for invitation. And you can see my screen.
Not yet.
Right
Green
now,
button at the bottom of your screen, green button, share screen. You must.
I put that. No. You can't?
Not yet.
I don't know what happened. Sorry. You can see it?
No. The technical team can they help us?
Yes, Ahmed IT, can you tell Professor Rodolfo how to open the PowerPoint?
Yeah.
Ahmed, Rodolfo, did you open PowerPoint already in your computer?
I open my PowerPoint presentation. I comparting the screen, but I don't know what happened. So sorry.
Can you just close the PowerPoint and open again?
Yeah. Share screen. You must first share screen. The green button at the lower part.
Yeah.
Do you click it?
Yeah.
It doesn't work?
No.
Then you can select your PowerPoint. Green button,
Yes.
and select your PowerPoint.
I select PowerPoint and I select the screen with you and the speaker, but can you pass for the next speaker and I try to fix that? For the time.
Of course, Rodolfo, but we just need you to make another trial. Just go down, you find green button, share screen. Just double click over this share screen, please.
I do it.
And now your PowerPoint is minimized.
Yeah.
Minimize the zoom and you will find that the PowerPoint is working.
You can select the PowerPoint, then you push the right below the corner.
Okay.
Green button, you can select, then put the right under the corner. So 3 steps. Green button, select the PowerPoint,
yeah,
right under the corner. Select, share.
Maybe we can come to the discussion session.
I think Mehmet, Professor Marisa, she didn't show her video. I don't know if Marisa, she would like to make another trial. Marisa, are you here?
Sorry.
Marisa from Argentina. Would you unmute your mic, Marisa? Okay, until Rodolfo becomes ready, Professor Mehmet Zelili will open discussion and then we go back to Rodolfo again.
Okay.
Yeah.
Now, we have some questions, starting with the first speaker, Dr. Koichi Sairio from Japan. Dr. Musa Ibrahim has asked to Professor Koichoi, thank you for the wonderful presentation on Kilif. My question is, what average distance do you take from spinal process for the foraminoplasty and percent of facetectomy, if any? Thank you.
The skin incision is from central to like 8 centimeter skin incision. Then we put a cannula. Then starting foraminoplasty, actually facet contact is preserved. Just outside of the superior articular process is shading. Then making a Cambin triangle is bigger. So facet joint is completely preserved. I shaved.
You don't remove any facet?
No. Facet joint is preserved. Just lateral aspect of the superior articular process is shaved. So facet joint is preserved.
Okay, thank you. I think Dr. Rudolfo is ready for screen sharing.
Yeah.
So then we can start his talk and then come to the questions again.
Okay, I'm so sorry for the return, and thank you very much again for everything. I'm Dr. Guerrero from Mexico. Thank you, Dr. Nazar. Thank you, everybody, for staying with us. Try to speak in a couple of minutes about what happened with the patient who have a degenerative spinal and not is ready for fusion, not have something like the experience of the surgery, and the more important for me, the quality of the life of these patients. And in the cases when you have a patient more than 65 years, maybe with a problems with the collagen type 2 traumatic history, but the patients not are ready for do the open surgery, minimal invasive surgery, or why not have the money for that? You know, when with the pass of the time, we have a problems with the normal nucleus systems of the vertebrae now, produce a damage in the matrix and produce a proteoglucan enzymes dizziness. And that's problems produce a degeneration of the vertebrae. And that is the normal. When you do it or see that type of the X-ray, that is the normal. Try to preserve the stabilization of the spinal and try to do it something for help more for the pain and degeneration problems with the walk. But what the patient want? Really like to do it a fusion, really do it to change the life because in many cases he's an old man. Does the patient resist because have maybe problems, cardiac problems, lung problems, liver problems? What is the quality of the life we do it from the patient, and what is the risk benefits? This type of the patients maybe is possible to offer something different than the fusion, and that is the part of the topic. Hippocrates say primum non nocere, no? You can see in the video, this is the good patients. This is a healthy patients, it's a young patients, which you can see a biportal approach about the decompression of the flavum ligament only for radiculopathy in a patient from 40 years, a female of 40 years. And that is beautiful because you open, you stayed in the place of the work, you see with your camera, you stayed in the flavum ligament, you may be taking X-ray. If you have other type of the tools, you can do it, but you can see it's very easy, it's very soft, it's faster. Maybe in 40 minutes, 1 hour, you stayed out of the surgery room. But the problem no is that. The problem is the patient who have a very big flavum ligament, not have a soft tissues. And you can see in these patients, it's very easy, it's the dura madre, and you state well, safety, and like the other professors say, is very good. But what happened with this patient? You can see in this X-ray have a problem L2, L3, and you have a one listhesis of L4, L5. And in the flexion and extension, don't produce a move of these levels, and you have a very big flavum ligament with a compression between more in the right and the up level in the left. And we can do it. That's the problem. The problem is you stayed in the place. You know, you stayed in the place in the biportal endoscopic approach, but the problem is the tissues are very hard, very, very, very hard. And in this moment, you need to do something for help with this patient. The more simple process is produce a fusion and maybe open surgery. That is a normal other neurosurgery or some spinal surgeries of rest for the patient. And it's very, very, very difficult to open this window. No matter you have the tools, the correct tools, you stayed in the place and it's impossible, little less than impossible. You try to do it with the drill, you try to do it with the Carrison, you try to do it many techniques. The problem is the patience of the surgery, because in the moment when you start to have problems, the more easy is say, open, change the surgery. Right now is different because the endoscopic surgery changed everything, and you need a lot of patience, a lot of change the format to the surgery, and be careful with every step, because when you try to do it everything fast, in many cases you produce a damage. In my cases, I have a minimal experience in damage of the nerve of the dura madre, but I know it's difficult to try when it's bigger, because you don't have the normal vision or possibility when you than the open surgery. And this important, you stay very safe and very careful. And the other type of principal thing in these problems is it's possible to do it from both sides in every patient. So all depends of the angulation of you put the channels the work. In these cases, in specific cases, this problem is for 4 levels. And if you do it only from one side, not for both sides, you know, produces instabilization of the spinal. And this is the video. You can see you have a very, very big flavum ligament. You have a very, 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 very big compression of the nerve. Is possible you see the fat, peridural fat form tissues around to the nerve and produce more compression. And when you start to fix that, the dura madre start to be free and give you more possibility to open and more possibility to decompression. In this moment, I prefer to take an X-ray. I have a dilatator and a special foraminal forces, because in this place is very, very easy in this patient to produce a damage. And in my experience, in my cases, I try to don't do it fusion if the patient is necessary, absolutely necessary, and the patient state be comfortable with that, and I know the change of the life is more careful, but without pain, and not produce degeneration of the next level on the down level before the fusion. For this reason, I prefer this technique from all patients every times no was necessary absolute diffusion 1 level or 2 levels, because in these cases it's necessary to do it fusion. In my cases is early, the treatment is open and endoscopic. And you can see in this patient in particular, I see the left side and the right side. And in this moment, change everything around to the dura madre, change because it's more free. In the first part of the video, you can see the fat is very, very close to the flavum ligament and is very close from the forces. Right now, with you put a little more water and you put a little more descompression, the fat and the dura madre is more down. And this part is in the moment you can see, or you can say that is good. The descompression is in good moment from doing something more than drill the facet joints or kit other level in these patients. I start to do it from the down to the up, because from anatomic, normal anatomic is more comfortable for me. And in this moment, I start to see the other side of the surgery. And after this, you see the patients very happy and without pain, because no have a fusion. In many cases, the fusion produce a lot of pain in the muscles and produce a lot of recovering. And in the old patients, it's very difficult to move and the rehabilitation, because have other type of the problems, the degenerative problems in the joints, the degenerative problems in the legs, the degenerative problems in many cases have arthritis, have other type of the problems. And no is good to, we give you more problems to the patients. That is the patients, 76 years old, 2 weeks after the surgery. She can walk before the surgery. She arrived to with the family from the office, and you can see the move is very safety, no produce a disability. She not have pain. She recovered the life and recovered the type of the type of the problems in the life, in the normal life. No, I don't produce more problems in the life of the patients. This reason, I'm sorry. Next. Okay, and the conclusion of this is, it's possible to do it with descompression, help from the people of the patients with this type of the treatment is more conservative than the fusion. Yes, it's possible. Is the best? Depends. The patient really need a fusion or no need really a fusion. You do it, all the tests is necessary to do it, from decide what is the best solution from the patient. If it's good patient for the fusion, do the fusion. But if no is necessary, the fusion, don't do it. Primo non nocere, remember, is safe, very safe, because you know, you see everything around around to the nerve and the dura madre. And it's possible to do it very safe. L2, L4, L4, L5, L5 S1. Yes, in the L2, L3, the degrees of the normal joints in the facetas is more close. For this reason, it's more difficult. But if you change the angle from the you work, maybe it's possible, but it's more difficult. But really, 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 the main thing is do not more harm. Thank you so much, everybody, and whatever question you have, please answer me.
Yeah, thank you, really, Dr. Rodolfo. I think we are a bit out of time, but we will try to answer some questions. we were talking with Dr. Koichi Sairio. Another question for him is from Dr. Sergey Eddy from Zimbabwe. He is asking, what is the conversion rate from MIS to open surgery when doing a transcombine route?
0%. 100%. I completely perform this surgery, no conversion. So for almost 30 cases, I completely perform this surgery with endoscopic guidance.
Yeah.
No conversion.
But can we say that you use smaller cages because you don't remove the facet?
Small, not width is 10 millimeter, and length is 30, 10 and 30. I don't think it's small. I don't think it's not small. I think it's big.
Okay. My question is, what is the advantage of this technique to TLIF surgery?
Really, we need to remove the entire facet joint. But my technique is we can preserve the facet joint. So we can insert the cage through the Cambin triangle, but the TLIF is we need a complete facet joint. We don't need a facetectomy.
But isn't it safer for the sake of root? No root.
Right. This is very important. This is not safe because existing nerve is right there. So we need a neuro monitoring and making a foraminoplasty, then the Cambin triangle making bigger, then put a cage. So if you just insert the cage, you may damage existing nerve. So I think not safe, but most important thing is you need to make a safer space for insertion of the cage. So if you make a space, it's very smooth and quick and safe.
Yes. Okay. Is Dr. Marisa Alejandra with us from Argentina? Is she with us?
No, she had problem with connection. But I think, Mehmet, we have a question for Professor This is from India.
Yeah, we had two questions for Marisa, but we can skip it and then we can come to the question to Dr. Javi Quilo Olvera, Mexico. Yep. Dr. Harshad Parekh is asking, do you remove full disc or just herniated part of the disc?
During biportal endoscopy, depending on the goal, but when you are fusing a segment, you need to remove most of the total disc. Why? Because you need to remove the fusion. So this technique, as all the endoscopic techniques, has the advantage to guide the very good and proper preparation of the intervertebral space to direct visualization. So we remove all the disc, not all the extruded fragment. Yeah.
In endoscopic decompression, we can behave like just fragmentectomy, but in fusion surgery, we must remove as much as possible soft tissues. Question for Dr. Hwajin Ohm from Korea. I want to ask for this extreme TLIF, you call it extreme TLIF. Am I right?
Yes.
What is the diameter of your tube and the diameter of the cage?
Diameter of cage? The size of cage, do you mean?
Yeah.
Yeah, cage is the same as Olive and X-Lip cage. The width is 18 and 22 millimeter, and length 18. Is 40. Yes, length is 35, 40, 45, and 50. We can use just the same size of olive and X leakage.
What do you think about the technique used by Dr. Koichi Sairio?
Because I think
Actually, you are in two extremes. You are removing most of the facet and then coming more lateral. But Dr. Koichi is making without taking any bone.
so. I'm sorry, but in Dr. Koichi technique, especially in the L5SR level, is not easy. This
Yeah, it's
because it can be yes. Sorry, but
that's true.
anatomically L5SR level, we cannot do with the through the Cambridge triangle. So
Yeah,
and some cases of spondylolisthesis case, instability cases, actually we don't need to keep the facet joint completely. Already facet joint is not functioning. So fusion surgery means we have to just fusion. Fusion will have to be done, okay? So we have to put we need I think the larger case will be fine, I think. It's my personal opinion.
You need a total facetectomy, yes.
Yes. So maybe in the L5SL level, in the Koichi, if you remove the pen approach to L5SL level, if you remove the facet joint partially, you can put your cage.
Yeah, actually very difficult. If you if we insert the cage using my technique, it's very difficult. So in such situation, I need to remove entire facetectomy for safer insertion.
Yeah.
So I need to remove a lot of the facet joint. Yes.
Okay.
So very similar to your technique.
Sorry.
I went very similar to your technique.
Yes, very similar. Yes.
Sorry. Dr. On, Professor Zhang Wei is asking you a question. Can you share your experience of how to deal with the disc space, especially the contralateral side?
Yes, very good question. Because even if we are doing open surgery, contralateral preparation is not easy. So I usually use a special designed curette like that. So we have to use all kind of specially designed curette. Okay, so it takes a little time. Okay, even if in open surgery, it is not easy to remove the contralateral side disc and the preparation, I think. So it takes time.
The last question is to Dr. Koichi. Do you use reamers for safety?
No, I'm using a drill, not reamer. I'm always using a surgical drill. The size is 3 millimeter. Just a drilling. No use reamer.
No curettes? No curettes?
Curette. I use a curette for intradiscal shape. I use a curette in the disc.
Okay. Thank you.
Mehmet, I think Marisa is trying to connect. I don't know if she's available. Marisa, did you already join? She's trying to connect now.
Okay. We have some questions for her.
Yes, I think we have some questions.
Dr. Sairo, can I have a question?
Yes, please.
Dr. Sairo?
Okay.
Okay. How long does it take for your technique? Just one level?
About 2 hours.
2 hours.
2 hours. How about your technique?
Oh, about 3 hours. One level, 3 hours.
Because you need a lot of bone rejection. My technique is bone rejection is only small.
Yes, that's right. Actually, I used your technique as a reference. Okay.
Okay.
Your technique is very important.
Thank you so much.
So can you do your technique in local anesthesia or spinal anesthesia?
Yeah, actually general now.
General
But
anesthesia.
I think it is possible using a local. But so far, I'm doing this technique in a general anesthesia.
Thank you very much.
Thank you.
What do you use, Dr. Local or general or conscious sedation, or what do you use right now for biportal fusion?
For the fusion surgery, as for me, sometimes depend upon the patient condition, sometimes just a sedation, and sometimes epidural anesthesia. But I recommend if the patient is healthy, I recommend general anesthesia.
Yeah, sure.
Dr. Marisa, are you connected? Marisa?
She's
No.
connected without audio. She had problem about internet. Now I think she's connected. I will ask her to unmute. No.
Please unmute.
Marisa, would you unmute your mic and answer our questions, please?
Dr. Marisa? She has difficulty in connection, I think.
Yes, I can see that
Yeah.
she's available online, but her mic is not working. Marisa, again, would you unmute your mic and listen to our questions?
We are available. Yes, we're here.
Yeah. Dr. Marisa, one question from Dr. Sergey Eddy. How do you deal with unintended durotomy in the transsacral approach? If you injure the dura, what do you do? Do you hear us?
Are you listening to us?
Yeah, we hear you.
We only had one case of durotomy where we could see all the radicular arteries, and we knew we were inside it was miroscopy, and we sealed that tear with sealant, with biological sealant, and did not have any leak, any LSR leak. There may be inadvertent durotomies, we are aware of that, but they were never a problem to us. They were never an issue. We never had any external leak at all.
What about the injury to the nerve roots? Because you use laser in anterior part of the dura, and if your laser goes to the PLL, then you can shrink the disc. But if it goes to the nerve roots, you can cause some damage to the nerves. Did you get any experience with that? Any complications? Dr. Marisa? Okay. I think she has no good connection, and we can close the session. Dr. Nasser?
Yes, I think we can proceed to the second session in this webinar. Mehmet, would you introduce? She's here now. Okay.
Can you listen?
Yes.
We had no trouble with laser. Is a very safe instrument. We have a new laser with a probe that only delivers energy only in the point of the laser probe, not around. So we really didn't have any issues with that. We've been using it since 2017 when we brought it from Japan. It's a new laser. We can show you the pictures of the laser afterwards. In other eras, we used another laser, and we only had some dissociation. We never had an injury with the laser.
Thank you. Thank you, Dr. Marisa. I will finish this session and then start to the new panel. In this panel, the first speaker will be Dr. Malcolm Pestonji from India. He will tell us the spine endoscopic fusions next frontiers. Dr. Malcolm.
Am I mute or? Just 1 second. Yeah.
Malcolm, we can see your screen. We can hear your voice. Just maximize your PowerPoint, please.
I'm doing that. Please give me 1 second.
Take your time.
Dr. Nasser, it is
Yes.
my pleasure to speak again at the opportunity given by you. So I'm very grateful to you, sir. And it is my honor to be with you today again. Dr. Mehmet, I think this is the first time we are meeting. It is my pleasure to be speaking with you again. To all the panelists who are present, thank you. From India, I'm Dr. Malcolm, and I will be starting, actually all our talks are quite similar. Little differences in technique, little differences in the presentations, but basically the end goal is let's achieve fusion. So lumbar spine endoscopic fusions are the next frontiers. Why am I not? Just 1 second, my laptop is hung up. Go back.
Good morning, welcome to Golden Park Operation Theatre, Endospine Suite. Today we are doing a case of transforaminal endoscopic spine fixation. We'll be introducing the cage through the foramen without violating the facet, and we'll be doing minimally invasive posterior screw fixation with reduction of a patient of degenerative listhesis, as you see over here. The L5 is moved ahead on the S1. There is collapse of disc height, and we can see that in extension there is partial reduction of this, but in a flexion view, you can see that it's a grade 1 to grade 2 listhesis. Now, if you see here in the MRI, you can see there's a huge broad-based disc bulge because of the listhesis. It's a very tight foramen. Bilaterally, patient is having severe claudication. There are wet facets that are observed, thickening of ligament flavum, but basically the sac size is quite capacious. So I feel that by getting a good distal height transforaminally and minimally invasive fixation and debulking this posterior discal surface through an inside-out approach, we will be able to restore this spine to its normalcy. This surgery is basically being done under local anesthesia, where the entire cage will be inserted under local anesthesia to the patient. And subsequently, after patient is given a sensory epidural, we will be putting in with local aided 4 minimally invasive screws. The top 2 screws will be reduction screws, and we should be able to fix up her spine with the cage loaded with bone graft from the iliac crest. And hopefully she should be on her way to recovery. So thank you very much. Let's hope we get a good result today.
I don't know why is my presentation misbehaving.
Start. Yeah, what we are doing now is we are curating the end plate. Okay. Make sure that the graft that we put in through the cage has a good chance of union. And can you please bring the C-arm in front, Mr. John? And now we'll be taking a live shoot. And Shirley is going to focus on the screen. Don't run to the screen, please, Shirley. Yes. Give me a live shoot, please. Continuous. Yes, thank you. And as you can see, continuously shoot. Here now, John, please. And as you can see, we are now creating entire space inside. 1 minute, please hold steady now. No, don't shoot now. John, 1 minute. Shoot, please, John. Yes, now you can see that the curate is bent. And I'm trying to curate towards the upper end plate. Okay, wait, please, John. Shoot, John. Only single shoot. Single shoot. Single shoot. Shoot, John, live, shoot, car. Yeah, now you can see the gradual movement of the curate towards the upper end plate. We're creating the center of the disc. Okay, thank you so much. Stop shooting. Completion of end plate preparation. This is the superior end plate, which has been stripped and prepared. Now I'm rotating the tube to expose the end plate preparation of the S1 vertebrae. So both the surfaces are now prepared and are ready to receive the cage. There are a few loose fragments which are being pulled out, flushed out, and we are ready to place our cage. Grafting. Good. 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 Ask her to move her legs, please. Focus on her face.
ते बघा पाय पाय उचला पायाची बोटं हलवा वर खाली करा.
Yeah, ask her to move her legs. Wonderful.
Is she
having any pain?
दुखतंय का तुम्हाला काही? हा तोंडाने बोला.
Shoot, John.
दुखतं का? नाही ना?
Shoot, John.
ठेवा डोकं खाली ठेवा. हा एका बाजूला करा. दुखलं तर सांगा.
Shoot, John. She any pain? Ask her, please.
दुखलं तर सांगा. आई दुखतंय का काही? कमरेमध्ये किंवा पायामध्ये?
The case properly engaged now. A thorough decompression being carried out from the opposite side. One can see the cage that has been inserted from the opposite foramen. One can see the entire annulus which has been de-roofed and decompressed. There is no material, annular material or nuclear material posterior to the cage now that can be retained and be a cause of pain. So biportal endoscopy with insertion of cage through one of the foramens.
I think I shall start speaking now. Our experience has been in degenerative retrolisthesis, in lysis listhesis, and in severe canal stenosis. Lateral canal stenosis, not central. As you can see here, this is an image of a patient with a 4-5 and above is with L5S1. And you can see that the reduction even in the retrolisthesis is pretty good. Opening up of the foramen is pretty nice. Transforaminal fusion is a distinct possibility. Here you can see that this has been done in a patient with a 4-5 listhesis, with the 5S1 segment being quite okay. You can see the scars on the patient's back. It's absolutely minimally invasive, and patients tolerate it under local anesthesia very well. They do their own neuromodulation. We are a poor country. And it becomes much more easy when the patient is awake, aware, and cooperative. Transforaminal endoscopic cage with minimally invasive screw fixation. What I thought was a dream is today a viable thing. Unlike Dr. Koichi Sairo, I do not prefer to do or even touch the facet. I feel there is enough space. And if there is not enough space, then I don't do a transforaminal endoscopic fusion. I opt for UB TLIF. Transforaminal fusion, facet sparing transcambin fusion or pure transcambin fusion. It retains the integrity of the facets, especially where there is retrolisthesis or where there is degenerative listhesis. And moment you add to the height, you are adding to the structural stability of the whole spine and the whole construct becomes tight. You are not creating instability, therefore you are in no way worried about future instabilities. Annular entry is far lateral. Implanted cage will be more horizontal. So I balance it out. My entry point is usually somewhere around 11 to 12 centimeters, going even up to 13 centimeters. Failure of implant will not result in a complete collapse or crushing of an exiting root between two pedicles should something go wrong. As spine surgeons, we always follow the dictum, do no harm, but it's not necessary, that you may do harm on the table, but harm can occur later on. Screws are known to break, rods are known to pull out, inis are known to fail. And at such times, patient can get into bad trouble if fusion is not occurred. TLIF basically is a misnomer or its classification of fusion approaches, but does not specify facetal destruction, though it has come to imply it. We say transfacetal fusion, but we are not very specific about what we mean. Is the creation of instability by removal of a facet justified in achieving stability by fusion? That is a question sometimes that we need to ask ourselves. In the possibility of non-union and implant failure, what happens in patients with associated iatrogenic facetal loss? So therefore, I believe that there is a role for facet sparing fusion. There is a role for TLIF. There is a role for UBB endofusion also. Now, this is a slide of a patient in whom I have done endo-TLIF. There's a distinct visualization of the traversing root. I'm at the shoulder. There is a more vertical positioning of the bullet cage. I have tried to spare a part of the facet. And instead of going far lateral, I have just lateral, you can say. So it's unlike what Dr. Yumjin has been speaking about. It's more of a standard approach. Here you can see the video of me positioning the cage.
Alignment of the cage with the canal.
The unfortunate part about this little thing is that in UV endo-TLIF, you do not get to see a 360-degree view of putting in the cage. You are restricted. Vision restriction comes in from one side. And I believe that Dr. Wei Zhang from China has now developed a third portal. I intend to try that to see if I can get better visualization of a cage during insertion. But here you can see me inserting a cage loaded with bone graft via endo-TLIF. Patient has done very well. Cage went in beautifully. Positioned it almost 10 millimeters inside the posterior vertebral line. Carried out a unilateral compression. These days, I try, if I can spare the facet, I try to do only a unilateral fixation. I do not do a bilateral fixation. Though there is dispute in that, but we leave that out of that scope right now. And here you can see me positioning the cage nicely inside. Now this is what I speak about. And when I'm going to play this slide is about the horrors of endo-TLIF. In transcambin TLIF, which I do, I don't see the roots. I'm away from the neural elements. My tube or the tang of my tube protects the exiting nerve root. The traversing nerve root is protected by the facet. But in endo-TLIF, the neural elements are open, and this is the disaster I had on table. But I think it is important that one shows one's mistakes also during presentations rather than glorify them or gloss them over. And you can see I have a tear at the shoulder. And I tried to fix it, I couldn't, so I had to open up this patient and I had to repair the tear. So you can see the nerve roots prolapsing out. Not a good thing to show, but then this is reality. And we should speak of realities if we are going to proceed further and improve and evolve into better surgeons. Endothelial if my favorite in case of adherent plastered nerve roots and dural sacs in case of redo surgeries where visualization of the entire course of the nerve roots, its adherence to the facetal walls, its adherence to the discal surface. And if you try to do a transcambin approach, you may actually even tear the root apart and not realize what is happening. So here endothelial is my favorite. Here you can see I'm showing you both the edges of the facet. I'm osteotomizing the facet and slowly chipping away on the facet, removing this facetal bone. It is good because you are getting autologous bone graft. Here you can see the discal surface is so adherent, it's just stuck to the exiting nerve root. There is a bony bridge on top of the nerve root. I need to fracture that, I need to free the nerve root. And as you can see the gap, because of a previous surgery, there is hardly a 1 millimeter gap. I had to explore to find out the discal space and then enlarge the whole thing, protecting the nerve root at all times. So in cases of redo surgeries, especially, I believe endothelial is a gift of mankind from Dr. Yung Jinwa. And I'm really grateful to him for having developed this technique, along with Master Son, I believe. They were the first pioneers, and the world owes a big debt to Dr. Yung Jinwa for this, especially the endoscopy world. Here I am struggling a little bit, but I'm coming laterally. I'm fracturing the bone, which is on top of the nerve root. Then I'll be exposing the foraminal ligament, which is on the nerve root, securing the nerve root, opening up the disc space, and then carrying out a fusion. So this would not have been possible through a transcambin approach. Now, what I'm trying to stress about, gentlemen, is that no one technique is the solution to everything. No one technique. Let's accept that the fact that the world is today moving towards an era of what you call as, what I have started labeling as a 360-degree approach to endoscopy. Some things, yes, wonderful transcambin through PLD. Some things wonderful through endothelial. Some things wonderful through anterior cervical endoscopies. I started doing fusion over there also. Unfortunately, today's talk is restricted to the lumbar spine. So here you can see how I fractured away that piece of bone that was on the nerve root. Now here I'm introducing a spacer and cutter, and subsequently introducing the cage. So from a badly, hardly 1 millimeter gap, it would not have been possible to do this through transcambin. Here, endothelial, perfectly executed. Really appreciate this surgery. Today, I have come to now the controversial part. Sometimes I combine both. Autologous bone graft from one facet, along with a little bit of artificial Kronos bone graft and a mix. You can see at the upper level, I've done an endothelial. At the lower level, I've done a transcambin TLIF. I've mixed both. Now you'll wonder why. The answer is in this MRI. If you see carefully at L3-4, there is an absolute collapse, retrolisthesis, totally collapsed disc space. And it would have been very difficult for me to do a transcambin sparing the facet. Otherwise, like Dr. Koichi, I would have to remove a substantial part of the facet. So there I preferred to do an endothelial. I felt it was safer. I felt that maybe there may be some adherence, there may be adhesions of the nerve root. Foramen is badly collapsed, compressed, and I should go for an endothelial if I did an endothelial. At the lower level, you can see at L4-5, there is a disc, there is a foraminal, extraforaminal fragment that needs to be taken care of. And there I felt, okay, maybe transcambin, my favorite. So today, these days, I've started combining both. So going back to show you that image, mix and match, whatever is easy, whatever is your mood, whatever matches you. But the end result and end goal should be good fusion, stability to the patient. So this is that X-ray of the same patient where you can see at L3-4, literally no gap. At L4-5, marginal anterolisthesis, but the foramen is quite nice and open. So I chose to do a transforaminal over there. This was in an old lady of 90 years under local anesthesia and then under caudal epidural motor anesthesia for the endothelium. Now, advantages and disadvantages. This is the boring part of the talk. But in facet sparing endofusion that I do, I preserve both the facets. My cage insertion is under local anesthesia. In a second stage of epidural anesthesia, that is caudal epidural anesthesia, like Marisa passes the scope, I pass a catheter. And that time I give a little bit of epidural anesthesia, dense motor, not dense motor, dense sensory. And I put in my screws and rods. Patient is awake, which is what I try to show you, doing his or her own neuromodulation. Blood loss, transforaminal less than 50 cc's. Visualized end plate preparations, like Dr. Koichi specifically mentioned, 0 accidental durotomies, but you can cause a little pull on the root. You can have some root dysesthesia. And if you're not careful, yes, a root tear. I have not faced anything like that, so I'm grateful to God Almighty. Ideally in elderly patients with multiple comorbidities where GA is just ruled out. Disadvantages, you cannot resolve central canal stenosis. Cannot be done for old redo surgeries, which I tried to show you above with severe root entrapments. Little expensive infrastructure, needs a lot of endoscopic training. Posterior endothelium advantages, yes, you can visualize the dural edge, nerve root and its entire path. Ideal for associated central canal stenosis, facetal cysts, other pathologies. You want to go ahead and do a contralateral undercutting of the facet, what we call as ICELF, to relieve the other side foraminal stenosis, that can be done. Ideal for redo explorations where nerve root entrapment is severe and root has to be explored from the dura to the extraforaminal region. It is easier for a traditional spine system because you have been used to this anatomy. You have always seen this. So if you have dabbled a little bit in arthroscopy and you can manage triangulation and creation of a reservoir and what Dr. Xavier spoke upon so beautifully, I would definitely tell people to adapt to endothelium for biportal endoscopy, basically. And like Dr. Yumjin showed a very beautiful presentation, you can put in massive cages, which is what I'm not doing, but I intend to go visit him, learn, and do it. Disadvantages, epidural general anesthesia is a must. Possibility of a root or a dural tear, which I showed you, which has happened in my own surgeries. And blood loss definitely is a little more in comparison. So I thank you all. I hope you all have appreciated an honest presentation. Your questions are all welcome at the end of the sessions. Thank you. I shall stop my screen sharing.
Thank you, Dr. Malcolm. Yeah, very
Thank
interesting.
Endovision.
Very interesting.
Now I will stop screen share.
Yeah.
I hope I was loud and clear, Dr. Mehmet.
Yeah. Thank you. Thank you a lot.
I can't hear you.
Talk.
Hello.
Now we can switch to other speaker. We will discuss later. The Dr. Xu Weibing from China will tell us the history and techniques of biportal ULBD.
Okay. Can you see me PPT?
Yes.
Yes.
Yes, we hear you.
Thank you. Thank you for invitation. I'm Weibing Xu from China. My topic is the history and the technical details of UBE, ULBD. My topic include three parts. First, the history of ULBD. Second, the lumbar UBE ULBD case. Third, the thoracic UBE ULBD case. ULBD means unilateral laminectomy for bilateral decompression. The indication for ULBD include central spinal stenosis. Second, both side lateral recess stenosis or combined with some foraminal stenosis. This is the indication for ULBD. Let's talk to birth of ULBD. In 1995, an American doctor, Dr. Polky, came up with the idea of unilateral laminectomy for bilateral ligamentectomy to treat two cases of lumbar stenosis caused by ligamentar flavor hypertrophy. The author believes this technique can preserve parts of vertebral arch and the spinal process, as well as superior spinous and the interspinous ligament. So the ULBD can reduce the spine instability caused by wide laminectomy. This is the birth of ULBD, come from American doctor. A German professor, Spendiger, formally describes the technical details of ULBD under microscope in 1997. It is a cadaver study. It's a cadaver study. From the paper, we can see contralateral traversing nerve root, ipsilateral traversing nerve root after the SP-based resection and the bilateral ligament flavor resection. So the ULBD based the concept of reducing the post-operative instability caused by extensive decompression surgery. In 2015, Egyptian Professor Solomon published bipolar ULBD. This is a figure. And Korea Professor Jinghua Earn first he also be called Korea UBE father. Jinghua Earn published the UBE ULBD in 2017. Let's see some case. Let's see my case. The first case is a 70 years female. The diagnosis is severe lumbar stenosis and spondylolisthesis grade 1. It is no instability. It is a fixed spondylolisthesis. And the third, cauda equina syndrome. What's your treatment option? Maybe PLIF or TLIF or wide laminectomy or BLIF. Because the spondylolisthesis is fixed, no instability. I choose decompression only, UBE, ULBD. It is base comfort feeding. Cranial caudal SP base here, AP. Interlaminar window is very narrow. We do the laminotomy with calcium punch or osteotome. Ligament flavor. Then we separation the adhesion between the ligament flavor and the dural sac. Ligament flavor and the dural sac. Under the arthroscopy, we can see clearly, so no dural tear. It is contralateral exiting the road. Exiting the road, contralateral traversing the road. Pedicle wall. Ipsilateral traversing the road. So we decompressed 3 nerve road. 3 nerve road. Pre-OP and post-OP CT and MR. This is the first case. Second case is central spinal stenosis combined with lateral recess stenosis and foraminal stenosis. Let's see the technical details of UB-ULBD. First, basement camper building. SP base, AP, lamina, deeper ligament flavor, deeper layer of ligament flavor. This is the basement camper building. First docking set is the junction of SP base and the inferior edge of superior lamina. The first docking set is here. The first docking set of bipolar. We do the ipsilateral bone work where a U root. First, SP base, and the second, inferior edge of supralamina, and then medial edge of AP, and then the superior edge of inferior lamina, and then distal SP base. It is the U root of ipsilateral bone work, U root. When we do contralateral bone decomposition, the key point is just over the deep layer of ligament flavor. Contralateral AP cord set. This is the deep layer of ligament flavor. So when we do the over top technique, we must just over the deep layer of ligament flavor. It is the key point. Otherwise, you may be lost your way. Contralateral SAP. Then we do the contralateral recess decompression with calcium punch or osteotome is okay. We can also do contralateral foramen decompression. It is a tip or SAP. We do the resection with osteotome to decompress the foramental stenosis. Then we take it out with a curette. Curette just like a hook. Take the SAP tip out. So we decompress 3 nerve rods, pre-OP, post-OP. We also decompress 3 nerve rods through UB ULBD. Third case is a thoracic ULBD case. The diagnosis is thoracic stenosis caused by ossification of ligament flavor. We do the ULBD where UBE docking site. Ossification of ligament flavor. First, we find the central folding of ligament flavor from the disc SP base. And then we do the contralateral decompression along the deep layer of ligament flavor, step by step. Okay. Pre-OP, post-OP, CT. Five days after operation. Last case is a spondylolisthesis grade 2. Spondylolisthesis grade 2. MRI. We do the UB fusion and the ULBD. Okay. UBE is an endoscopy assisted open surgery. Thank you.
Thank you, Dr. Xu. Your very interesting presentation. But the questions will come later during the discussion. And then we will switch to the next speaker, who will be the Seok Bong-jung from South Korea. He will talk on biportal endoscopic interbody fusion in lumbar spondylolisthesis. Yes. We see your screen. Dr. Jung.
Can you hear me?
Yes, we do.
Yeah. Good evening. To begin with, in the midst of a global pandemic, I want you to be careful of coronavirus. I am Seok Bong-jung, orthopedic surgeon in Jinjubon Hospital in South Korea. What I'd like to talk about today is biportal endoscopic interbody fusion in lumbar spondylolisthesis. As you can see at the below, a biportal endoscopic surgery has a lot of advantages, especially in biportal lumbar interbody fusion. There is no transfusion, quick recovery, no infection. Let me start by looking at 5 different bipolar technique. This picture shows the lumbar above the herniated on L45. This video overview the surgery. It takes time about 27 minutes. Lumbar disc herniation foramina. This foraminal disc rupture on L45 right side. This video, this is SAP. Disc space, right is axial root, exiting root. Cutting the disc space, remove the disc. Preserve the exiting root. You can see the exiting root. It takes time about 30 minutes. Lumbar decompression is stenosis. Left MRI is preoperative. Middle picture is post-operative MRI. Average time is 38 minutes. This is ipsilateral decompression. When rotating the right source of the scope, 180 degree contralateral side decompression. We got the sufficient decompression. Cervical paraneoptomy and discectomy. Average operation time is 40 minutes. C6, 7, left side disc rupture. It is separate. Upper partial laminectomy, ligament flavum, remove the ligament flavum, cut the annulus, and remove the disc. It takes 40 minutes. Lumbar interbody fusion, it takes about 80 minutes. This left one is preoperative spondylolisthesis. Middle X-ray is post-operative. This video is overview the surgery. Medial facetectomy, disc preparation, cage insertion. This picture shows the open surgery. The left one shows the 3-level conventional fusion with 3-point transfusion. Right one is oblique lumbar interbody fusion. So the picture in the middle shows severe scoliosis. Right is post-operative X-ray with 3-point transfusion. But bipolar endoscopic lumbar interbody fusion, left side preoperative, right X-ray is post-operative. It takes 1 hour 15 minutes, and hemoglobin level was decreased from 13.4 at 12.3. Bipolar picture left one is stenosis, right one is post-operative X-ray. This is overview the whole the surgery. Partial laminectomy, medial facetectomy, partial laminectomy, medial facetectomy, remove the ligament flavum, cut the annulus, disc preparation, and the cage insertion. Before the inserting the cage, we have to have end plate preparation, and then we grab the local bone into the disc space. This video shows the local bone graft through the funnel. Many bipolar surgeons use 0-degree scope, but I used 30-degree scope from the beginning. 30-degree scope has a wider view, as you can see it in this video. Here is the video comparing 0-degree scope and the 30-degree scope on the same patient and the condition. First footage is 0-degree scope. This is 30-degree scope, same patient. 30-degree scope showed wider view of tops, bottom, and left and right. Bipolar surgery was performed from 2015 in 2,100 segments. Among them, interbody fusion, 220 segments, and 116 segments is spondylolisthesis. Skin incision and approach is a very important factor to make it succeed, especially for beginners. For interbody fusion, 2 skin incision is located above the each pedicle, a little more lateral than discectomy approach. Because you should do a pedicle screw fixation through this incision. The picture on the right shows the OP wound 3 weeks after the surgery. This is decompression incision. This is fusion incision. In the right region, standing on the right side of the patient, you must grip the working or digital portal with left hand because the slope of lamina rises toward the digital part. In case of stenosis or fusion surgery, sometimes you can change the location of the portal for sufficient decompression of hard to reach places. In other words, you should be able to use both hands in the working portal. When inserting the cage, you need to use the proximal portal because of step off from the spondylolisthesis. We also took a video for your better understanding. I grip the working portal with the left hand. By using bow and punch, we can carry out hemilaminectomy and then remove the ligament flavum and perform the contralateral side decompression and remove the medial facet and disc. After disc space preparation, you graft a mixture of local bone and DBM into the disc space and insert the cage on it. For interbody fusion, when inserting the cage, be careful of upper level exiting nut. This is L3 root, traversing L4 root. This is line is disc space, cage insertion. Be careful of exiting nut. Picture on the left shows on 3-4 stenosis on 3-4, spondylolisthesis and 4-5. The middle one is post-operative X-ray. This video was shortly of the surgery, radial facetectomy, disc preparation, and the cage insertion. When you carry out the surgery for spondylolisthesis, there is several things to be careful for. Sometimes ligamentum flavum and dura are sticked together, so when removing ligamentum flavum, dura can easily tear. In the body with step up, exiting nut is close to the disc space. This also you need to be careful. Lastly, in degenerative spondylolisthesis, there is always facet hypertrophy. that might cause confusion because it looks different from the normal anatomy. This video is a short edit of the entire biportal lumbar interbody fusion surgery, partial laminectomy of lamina by using calcium punch. Proven the medial facet palpation and the medial facetectomy with the chisel. Remove the bone fragment. Remove the ligamentum flavum ipsilateral. You can see the dura. This is disc space. Rotate the right source of scope 108 degree. You can see the contralateral side, ligamentum flavum. Detach the ligamentum flavum from the bone, contralateral side, and then remove the ligamentum flavum. You can see the only removing the ligamentum flavum, you can see the contralateral lateralis. Disc space preparation, curating, and remove the partial end plate, limbing, local bone graft, after that, cage insertion. Remove the device and additional cage insertion. Okay. After that, you perform the percutaneous pedicle screw fixation. From now on, there is a case of interbody fusion in lumbar spondylolisthesis by using biportal technique. Male patients 54-year-old, the body of L4 and L5 is conducted directly. There is a lytic spondylolisthesis. Right X-ray is postoperative X-ray. That shows the restoration of the disc space and the reduction of listhesis. 74-year-old male patient, you can see the spondylolisthesis L4-5. Right is well done. 45-year-old female patient, this X-ray shows the grade 2 lytic spondylolisthesis. The surgery was well done. Right postoperative X-ray. 70-year-old female patient, the body of L4 and L5 will stick to each other. This case, we cannot have a reduction for listhesis, so we just have a decompression for root. This is exiting root. That is traversing root. So I institute fixation. 51-year-old female patient, this video shows change the portal position. First one is working portal on the distal side. From this point on, proximal side is working portal. So change the position portal. The decompression surgery through the distal portal. Also, you can see the insertion of the cage through the proximal portal. This is post-operative X-ray. 76 female patients stenosis, spondylolisthesis, and migrated rupture disc. We carry out the surgery with this method. Stenosis, listhesis, ruptured disc. Two-level fusion performed. 59 female dura tear case. In her cases, ligament flavum and the dura are stiffed, and the dura tear occurred during the operation. So we stitch up the dura with a 7.0 nylon. Ligament flavum adhered to tear the dura. So first one stitch before the insertion of the cage, and the cage insertion. After cage insertion, I performed the second stitch, 7.09. I recommend this patient bed rest for 10 days. 67 patients. In the video, you can see the exiting route close to the disc space. So you need to be careful when inserting the cage. Sometimes it's difficult to find the disc space due to step up on the body. This is a traversing route. Cage close to the disc space is exiting route. This is exiting route. 64 female patient who has already have lumbar decompression surgery 5 years ago, 2 level, degenerative spondylosis and severe stenosis. We performed revision surgery, interbody fusion with this biportal technique. Right one is post-operative X-ray. So I think this surgery would be a good surgical technique for the lumbar interbody fusion in lumbar spondylolisthesis. Thank you for your attention. Thank you.
Thank you, Dr. Jung. Very interesting talk. Very expert videos you have shown us. Thanks a lot. And we will get the questions afterwards. We have one more talk here. Dr. Zhang Wei from China will introduce his talk on application of additional third portal in UBE.
Hello, everyone. Can you hear me?
Yes.
Yeah. Good evening. I'm Zhang Wei from China. Thank you for your invitation. Today's my topic is the third portal of the UBE. I think UBE procedure is similar to the arthroscopy. So I think the UBE procedure is should not be limited by 2 portals. So today's content include the lumbar, the third portal, and the quarterback key portal, and the double cage insertion by the contralateral, the Jones portal, and the quarterback cage insertion portal, and the cervical UBE case by the third portal. First, there is the Jones portal. I think the indication, the first one is easy to do the decompression of the contralateral side. For my experience, especially in the early case, I found the contralateral symptom is not very good. I think the ipsilateral symptom, the result of the recovering is very good. So I designed this the contralateral portal to do the decompression of the contralateral side. And the third portal is often used for the complex spondylolysis. And I can get more autographs from the third portal. It's easy to insert the second cage by the contralateral portal if you want to insert the double cage. And for the compression of the contralateral side, when we perform the cervical UBD. This is ipsilateral the endoscopy portal, and this is the ipsilateral work portal, and this is John's portal, the contralateral work portal. How to locate it, the portal? I think the contralateral portal is the mirror position of the ipsilateral work portal. This is the position. You can see the knife, the tip of the knife is the location of the John's portal. And we open the incision and insert the root, the first, the grade 1 root. And this is endoscopy, and this is one root, another root through the John's portal. This is the door between the contralateral IEP and the contralateral SP. I insert the root through the contralateral interlaminar. You can under the monitor of the endoscopy. I insert the root, then I use the radio frequency to enlarge the contralateral portal. I think the angle is very good for the kerosene punch through the contralateral portal to do the decompression of the contralateral corner and the upper margin of the inferior laminar. You can see I use the kerosene punch, the 2 millimeter size, to do the decompression. And I also use the small size, the radio frequency to do the bleeding control of the contralateral side. And this is the contralateral corner area and lateral recess area. So it's very comfortable for me to do the decompression by the contralateral portal. Sometimes it's difficult for me to do the contralateral decompression by the ipsilateral work portal because there is a big angle, I think. So you can see it's very easy to do the decompression, the contralateral decompression. We can see the traversal nerve root of the contralateral side. This area is the upper margin of the inferior laminar. There is no special tools to do the decompression through the ipsilateral work portal. You can see the medial wall of the pedicle of the contralateral side. I often insert the drill through the contralateral portal. This is decompression area by the John's portal. You can see we can do the decompression of the contralateral upper margin and the corner and the lateral recess. So it's very easy, I think, for by the third portal. But sometimes for the beginner, it's very difficult to do the decompression through the ipsilateral work portal. I try to insert the second cage through the transporter. This is a cadaver test. I use the banana cage, and this is a UV retractor. This is endoscopy. This is a trio of the cage. I insert the reamer through the transporter. And this is the trial of the banana cage. This video shows how to insert the double cage. First, I do the decompression of the ipsilateral side. The left is the cranial side. The right is the caudal side. I use the big radio frequency to clear the soft tissue in the interlaminar area. You can see the above is the midline. The below is IAP. You can see the inferior margin of the, this case is L4. L4's up, inferior margin. This area is the surface of the L5's laminar. This area is the interlaminar area. You can see the superficial of the flavor ligament. I use the high-speed bore to do the bone work. I mix in the laminar. Then I use the kerosene punch to remove the laminar until I see the insertion of the proximal flavor ligament. This is the basement of the SAP. This is a bleeding area. There's many small vessels on the surface of the dura. I detach the contralateral fragment from the SP basement. I prefer to use the osteotomy to remove the IEP piece by piece. Then I can see the surface of the SAP. I do the decompression from the corner area. Under the corner area, we can see the ipsilateral traveling nerve root. You can see the blood vessel band from the pedicle. This is the ipsilateral pedicle medial wall. The vessel band is from the pedicle to the foraminal area. I use the hook to loose the blood vessel band to release the nerve root. The big size radio frequency is very useful for the bleeding control. on the surface of the disc. I open the angular fibers to make a window. Then insert the reamer to deal with the endo plate. This is the apsilateral side. I prefer to use the curate to remove the endo plate. I designed this the detachable cage trio. I think it is very useful. I detach the root, and you can see the remaining portion of the SAP. I can use this trio to test the space. Then I use the burn to remove the remaining of the SAP. To get the enough space. Then I remove the trio. This trio can also show the direction of the disk space. I build the transporter.
Órale, gracias. Se llama Marta Domínguez Rodríguez.
This is a contralateral portal. I enlarge the portal, and we can see the tip of the IEP of the contralateral side. I insert the curved osteotomy to remove the contralateral side IEP piece by piece. Then I can get more autograft for the fusion. So I can, after removing the IEP, I can see the contralateral side SAP, the surface of the SAP. Then I remove the tip of the SAP and the medial margin of the SAP of contralateral side. This is the isthmus of the contralateral side. I do the decompression of the contralateral side, the medial margin, and the corner of the contralateral side, and do the decompression of the contralateral side, the nerve root. You can see the SAP, the upper margin of the contralateral side. So it's very easy. Then I use the knife to open the contralateral, the annular fibers. This knife is inserted through the transporter. You can see the UBE retractor is inserted through the apsilateral side to protect the dura and the nerve root. Then I remove the disc fragment of the contralateral side. I also use the reamer. Insert the reamer through the Jones portal to deal with the contralateral side disc space. But the UB retractor is very important. I insert the trio to test. Then I insert the cage through the contralateral portal. This is the apsilateral side. You can see the contralateral side cage through the apsilateral disc space. Then I insert the apsilateral side cage. The double cage. The contralateral cage and the apsilateral cage. I also insert the two drill. This is a double cage. The quarterback key portal, the key means key valve. I think it can be used to mark the midline for the ULIF and to protect the nerve root and the dura and free assistant and make them happy. Make sure the cage in the midline. This quarterback portal is designed by the Korea surgeon. And this is my quarterback key portal. I draw two lines. One line is in the disc space level, and another line is medial margin of the spinal process. The cross point is quarterback key portal. First, I insert the key wire, 1.5 millimeter key wire through the key portal. The assistant use the retractor to protect the dura and the nerve root. Then I insert the key wire to block the dura and the nerve root. Then I can free the assistant. After the key wire can protect the dura and the nerve root. So I can insert the trio or the cage is very safe. I think is also comfortable for me and for my assistant. This is a quarterback. Another third portal is used in the extensive procedure. Especially we do the decompression by the perimedial portal, and we use the third portal to insert the big cage. Another paper shows the quarterback portal. This blue line is the lateral margin of the pedicle, and 2 centimeter is and crossed with the disc space level is the position of the cage portal for the extensive. The last one is the cervical URBD Jones portal. I also try the Jones portal, the third portal in the cervical case. The location is this area. This blue line is disc space level, and the green line is lateral mass line. So under the cross point, about 0.5 centimeter is contralateral portal for the contralateral decompression. When we do the cervical URBD, this area is ipsilateral decompression area for one level. We must remove the laminar and the upper margin of the laminar and the basement of the SAP. Then we can see the contralateral, the surface of the laminar, and do the contralateral decompression. This is the location of the portal and the position. And this is actually to show the endoscopy and the detector and the radio frequency through the contralateral side portal. This video show the one level cervical URBD procedure. I use the radio frequency through the ipsilateral portal to clear the soft tissue and to build the contralateral side portal. Then this is C5 and C6. I use the burn to remove the bone of the basement of the SP of C5. After removing the bone, we can see the contralateral side laminar of the C5. Further bone work so that we can see the contralateral laminar of the C5. It's easier to see the surface, the contralateral surface of the C6. We use the X-ray to confirm the lower margin of the contralateral C5 laminar. We did the contralateral bone work by the contralateral portal to mix in the contralateral laminar of the C5. To expose the contralateral lateral mass. This is the surface of the C6 and the lateral mass. Contralateral bone work of the C6 laminar by the Jones portal to mix in of the upper margin of the laminar. This is the contralateral side. the upper margin of the C6. I use the small size of the radio frequency to separate the contralateral flav ligament. Then I mix in the C5, the contralateral laminar. Again. This is a contralateral C5 laminar. Sorry, it takes too much time to play the operation video. Then I use the kerosene punch through the transporter to remove the flav ligament. This kerosene punch is about 1 millimeter or 2 millimeter and 130 degree. This flav ligament is the contralateral side flav ligament. And this inferior margin of the laminar of the C5. We remove the contralateral side flav ligament until we found the contralateral facet joint. You can see the facet joint. Then I finish the full decompression. The third incision allows the tools to be placed as a more comfortable angle and makes the decompression procedure to be more direct. Tried. We can only use the two portals at the same time, which is technically a two portals technique, just like the shoulder arthroscopy. Focus on solving the patient's problem rather than focus on the number of the incision. Thank you for your attention.
Dear Dr. Zhang, it was a very, very informative talk and very nice videos, really. But we are out of time, and then we must finish with the last talk. I will give a talk on the pros and cons of minimally invasive surgery. I wish you are able to see my screen. I will talk about the pros and cons of MIS surgery. This is my conclusion slide. Actually, the advantages of MIS surgeries are short hospital stay, quick return to work, and cosmetically better. Patients demand it more than surgeons, so then we are having too much stress by the patients if we can do their surgeries with an injection only or with the laser only. But one big advantage is less infection we will have if we do MIS surgeries. However, there are disadvantages like long learning curve, special instruments and equipment, tactile sensation and biplanar imaging. Complications may be harder to treat, safety concerns, more radiation to surgeon, and outcomes are similar to traditional surgery. And another conclusion slide, indications are same with conventional surgery. However, no damage or less damage to surrounding tissue, and outcomes are same and more radiation. There are different types of MIS surgeries. The main one of them is the image-guided percutaneous. Another one is the endoscopic. You have seen many nice presentations about the endoscopic. And then there are mini open surgeries, tube-guided, retroperitoneal, transpsoatic, MIS, pedicle screw fixation, and others. Probably the most minimally invasive technique is the vertebral body support, vertebroplasty or kyphoplasty we are currently using. But I will make my presentation by the type of surgery, the type of indications, MIS decompressions, MIS fusions, MIS deformity corrections, and give my conclusions. You have heard some MIS decompression in during this panel, but most of them were about full endoscopy. There is also a tube-guided surgery, which was first introduced by Foley and Smith in 1996. This is by placing key wire, then tubes for dilatation of the muscles. And then at the end, you can use either endoscope or microscope. This is the first setup I was using at the beginning by endoscope. Then I switched to microscope. The current tubes in the market is Metrix, EasyGo, and Destando tubes from Medtronic stores, and there are also some local companies in different countries. One advantage of the tube is that table-mounted fixator will allow you to turn your angulation and then in different directions. And you can also use microendoscopic decompression and discectomy, and also unilateral approach, bilateral decompressions, as was mentioned by our other friends from China and Korea. Far lateral lumbar disc herniation may also be done with this technique, and it may be adopted to cervical microendoscopic discectomy, posterior discectomy. This is one case from posterior cervical endoscopic discectomy. What about full endoscopy? Do they mean that if it is tube guided, it is half endoscopy? This is a difficult term, but it mainly means it is with water irrigation system. It was first introduced by Kambin, and Kambin has described the triangle, Kambin's triangle, by entering from the foramen of the disc herniations. However, more recently, Rutten has introduced interlaminar approach for herniation and stenosis. If you look at the indications for disc herniations, indications are not that much in transforaminal endoscopy, and L5S1 is difficult. The indications are larger with interlaminar endoscopy, and L5S1 is easier. So probably tube-guided surgery is one we are very familiar with. That was a bit modified with interlaminar water irrigation endoscopic system by Rutten. and you can also use drilling devices. Actually, our friends from China and Korea have introduced them very nicely. But there are disadvantages they did not mention. Stenosis drilling is harder, and learning curve is steep, and the baseline instruments are expensive. I don't think in developing countries the surgeons will can provide those basic instruments which are very expensive. As the remarks for endoscopic discectomy, tube-guided discectomy may be applied in all forms of herniation and spinal stenosis. Small modification of conventional instruments, baseline equipments are cheaper and may be applied with endoscope or microscope. Learning time is shorter. Translaminar transforamen endoscopy are more technically demanding and have restricted usage. What about MIS fusion? You have heard many presentations during this panel for pedicle screw fixation and T-leaf, A-leaf, X-leaf. Actually, if you look at the open surgery pedicle insertion, you will see that you dissect the muscles and then retract them too much and cause big damage to the muscles. If you come through the tubular retractors with widening or dilation of the muscles, you then make less harm to the muscles. This is quite apparent. But the MIS pedicle screw fixation needs very good knowledge of AP and lateral radiologic anatomy. You have to know that very well. Especially the AP views must be used. Sometimes CT navigation may also be useful. And many surgeons prefer using key wires, so then cannulated screws are inserted from the key wires. Placing the rod may be more difficult. Again, Kevin Foley has introduced so-called sextant system to introduce the rod. In the short fixation, it's not much difficult, but in the long fixations, especially in deformity, it's not that much easy. MIS pedicle screw fixation has advantages of smaller incisions, less muscle retraction and trauma, less blood loss, reduced post-op pain, less short narcotic usage, and shorter hospital stay. However, potentially longer operation, longer learning curve, loss of surgeon control, and more radiation for surgeon. What about T-leaf and other interbody fusions? As you know, there are many techniques, P-leaf, T-leaf, X-leaf or transpsoatic approach, O-leaf or oblique lateral interbody fusion or A-leaf. T-leaf may be done by a paramedian muscle splitting approach and under a larger tube retractor, 26 millimeter. A unilateral or bilateral approach may be used, and a more current technique, X-leaf, transpsoatic approach, was presented by Dr. Pimenta, which helps us to place a very large cage and special cages. Indications are from L1-2 to L4-5. L5-S1 is not possible in some listhesis cases and degenerative scoli cases. And indirect decompression of the foramen is possible with this technique. And some degenerative scoliosis correction may be possible with using very robust cages. Advantages are no need to mobilize great vessels, large lordotic cases may be used, easier in obese patients. No access surgeon is required, and high fusion rates. However, disadvantages are injury to the lumbosacral plexus. Because of that, it needs an EMG monitoring. There is a deep working channel, and posterior fixation still necessary. Because of L4-5 level, the incidence of L3 nerve root injury is quite high. Also, the genitofemoral nerve injury is quite high. Some surgeons have now stopped doing it L4-5 and do it at L3-4 and 2-3-1-2. An alternative to that is the oblique lateral interbody fusion to use a corridor between great vessels and the psoas muscle. So this is the point. And we can also have some other percutaneous fixation, transfacet fixation, Mager's translaminar facet fixation, or isthmus fixations in case of isthmic distasis. You can remember axial lift approach for L5S1 level by making it from sacral hiatus coming to the S1 level and then placing a trocar between the S1 and L5 and make some disc removal and then place a big screw or cage under distraction. This is the axial lift rod, and you can also place some bone grafts. However, there is an additional fixation. The need for additional fixation standalone is the non-union rate is quite high. Pedicle screws or facet screws, and high non-union rate. And because of reported major complications, especially bowel penetration and very severe infections because of that, it was left by most surgeons. What about MIS deformity correction? Can we do anterior or posterior surgeries? Actually, it was started thoracoscopic releases, then thoracoscopic instrumentations for MIS deformity surgery. However, currently anterior releases have been replaced by posterior techniques, especially small osteotomies. So then it was almost left by many deformity surgeons. What about MIS thoracoscopic instrumentation? It is possible, but it is technically demanding and very long surgeries and higher pseudoarthrosis and implant failure rate. And it was also left by, mostly abandoned by deformity surgeons. If we come to the conclusion, I must give that publication from 2009, collecting 1,338 surgeries. They reported that 10-fold less infection rate than open surgeries. So this is important, that infection rates are less with MIS surgeries than open surgeries. Disadvantages are with open surgery, more postoperative pain, longer hospital stay, cosmetically bad result, and tissue scar. MIS surgery need expensive setup, but baseline costs are very high. More X-rays for surgeon and team members, steep learning curve, and long-term benefits are not well known. But in general saying, patient demands our control of our techniques. So then we depend on the patients. And these are my conclusion slides again. I want to stop my talk here. I ask you to visit the WFNS Spine Committee website, wfns/spine.org. You will find many presentations there and then some recommendations of our committee. Thank you for listening to me.
Thank you very much, Professor Zelili, for this great talk. Actually, you made the conclusions of this webinar. And I think now we have Professor Andriy Hook. He is the secretary of the Ukrainian Association of Neurosurgery. Maybe he will comment and give us Ukrainian experience while dealing with these patients. Andriy, can you hear me?
Yes, can you hear me?
Yes, it's very good.
Greetings, and I'm very happy that I'm among such famous and unbelievable, fabulous lecturers and neurosurgeons. And special greetings to Mehmet. We all remember have you visited Ukraine. Yeah. So very, very interesting talks. But I have one big question to all our lecturers. We also have quite a big experience. Our Professor Pedachenko, he is a pioneer of mini-invasive endoscopic neurosurgery in Ukraine. So he was the first neurosurgeon who launched that 20 years ago. And we have around 7 departments within Ukraine, among 100 departments who really used very often endoscopic and mini-invasive spinal surgery. But the first introduction of in Ukraine, it was a mini-invasive. Some patients was thinking that mini-invasive is a mini-effective surgery. That is not true. And during this period of time, we also see that from the big amount of all our patients, unfortunately, only from 10 to 15% of patients can be operated, as especially Professor Zelili told that it depends of learning curve. So experience. So we have to have a training centers. We have many young neurosurgeons who are traveling and to different centers to learn about endoscopic, because the big mistake when people start to use mini-invasive without enough experience, and this we have some discreditation of this method among our neurosurgeons. I am head of endoscopic department, and but cerebral endoscopic department, and the spinal we only start now. We have in our institute, from our neurosurgery institute, we have 2 departments who well equipped and provide mini-invasive. But I can say that we are very cautious regarding the big operations that was presented today. I mean, if we are talking about fusion, and there are the common question to all our lecturers, how you can convince patients not move to mini-invasive spinal surgery when we have some contradictions. So in other case, how we can explain our patients that in certain patterns and certain cases we cannot use mini-invasive spinal surgery. Thank you.
Thank you, Andrew, very much for these valuable comments. Zelili, do you want to make comment?
Yeah.
About Andre, okay.
Yeah, thank you, Andre. Yeah, it's very nice to meet you here. Yeah, actually, I think the other speakers will also can also contribute to that. We need longer learning times to apply minimally invasive surgeries, and the complication rate is maybe quite higher in the first 50 cases or 100 cases. But we cannot escape from that. We need to teach young generations, but probably there will be new generations who have not seen very invasive open surgeries even. So then we need more cadaver dissections, more cadaver live teachings, and we need more fellowship programs for that. But we cannot escape. The patients demand it.
Yeah.
Another thing, there are significant advantages of minimally invasive surgery, a day surgery. You can operate in the morning, you can discharge in the afternoon. Another thing, the infection rates are very low. If you make such a surgery in a 80 years old person and with 1,000 milliliter bleeding or 1,500 milliliter bleeding, they cannot tolerate it. We need it. So then I am also somewhat more senior to learn some very new techniques, but I'm trying to adopt myself. Probably Mahmoud Qureshi will say something.
Yes, may I? Thank you very
Professor
much.
Nasser.
Yes,
Hello, Professor Nasser.
Professor Osama Al-Ghannam, Mahmoud, would you just give some words to Professor Osama Al-Ghannam? He would like to say comment, and then we take the comment of Professor Mahmoud Qureshi. Sure. Professor Osama Al-Ghannam is the honorary president of Egyptian Society of Neurosurgery and former dean of Azhar University in Egypt. Professor Osama, can you hear me?
Oh, yes, I hear you very well indeed. I must thank all the speakers, really very knowledgeable lectures, and they developing new techniques. But my comment is, I mean, if you look at the cases of lumbar canal stenosis, it's the element, I mean, instead of being triangle, it looks like a tri-radiate foliate picture. So it's not just the ligamentum flavum. I think the bone also is so hypertrophied, especially coming underneath the facet joint. This number one. I agree with the people who taking both ligaments and the bone. The other thing is, some cases I've seen it on plain X-ray. They are really fused, especially in plain X-ray and CT scan. I mean, if they are already fused, why should I fuse them more? And the last comment is, when you fix 2 or 3 vertebra, you would see the shift of the movement above or below. So you would have, by time after 2 or 3 years, you may the same spondylosis, same disc and same complaint. Thank you very much indeed.
Thank you very much. Would anybody would like to make comments to what Professor Osama Al-Ghannam has just said now? Mehmet?
Mahmoud, Dr. Mahmoud Qureshi.
Mahmoud Qureshi.
Thank you very much. Really, it's been an afternoon of very exciting knowledge and experience that has been shared through many very talented experts. My concern, and considering that this is a WFNS spine committee gathering as well, my concern is the amount of time that it takes, as everyone has mentioned, getting the learning curve of young neurosurgeons to reach the kind of level we have just seen. And I am concerned about what they refer to as the elephant in the room. Mehmet, you will know that just about a year ago or 1.5 years ago, the company, Karl Storz, which we use their endoscopes, began to withdraw the neuroendoscopes and scopes for us. And we had to fight for both the neuroendoscopy committee, the IFNE, and the other committees, and convince them to retract their decision. The elephant in the room is we are so dependent, we're becoming so dependent on these technologies. A young neurosurgeon will spend many years as a fellow trying to get to the level we have just seen, and then suddenly the companies withdraw the technical support. And we find that we have missed out on the microsurgical operating, which can be done through the tubes. And then we are relying on the endoscopic equipment, and the endoscopic equipment is no longer available to us. We are already facing those challenges in ventricular endoscopic surgery. They are not so readily availed to us, particularly in the low and middle income countries. So my worry is, and I think I'd like to hear the views of yourself from the World Federation's committee point of view, how appropriate is it for a young trainee or a resident or a fellow to spend so many years learning this technique with the risk that they will forget or never see, as you said, the open techniques, not be conversant or experienced with the microsurgical techniques through tubes and things like that, and then find themselves without technical support from the companies upon which we really are dependent, and they can suddenly take the rug out of our feet and we find ourselves lost. So that's my concern. And I think as leaders of future trends in neurosurgery and orthopedic surgery and approaches, we need to be cognizant that we may find ourselves left without, as they say, be up on the, have a boat on the creek without the oar, and you are lost. We don't know where to go. So I'm just raising that as a caution. Thank you very much for giving me the opportunity.
I think, Professor Qureshi, you are absolutely right. The other thing, it seems things does not means graft, so whatever artificial or cage or bullet or things. It seems, I mean, the company pushing too hard for that, which it doesn't make me happy. I mean, you know, I'm on old school. Stenosis means you have to make a wide decompression on both sides, and you have to make the nerve roots free, especially at the exiting nerve roots, because the patient. And the other thing is that probably nobody mentioned that the facet joint disease is associated with all these cases, and the treatment is not just fixation. You have to denervate, or what we call demuscularize all attachment of the facet joint. Otherwise, you did a very good operation and patient wake up in the morning with this severe backache and stiffness. Thank you very much.
Thank you very much. I think Mahmoud Qureshi raised a very important point. And my concern only for young neurosurgeons, they should know how to practice and address the classic procedures before starting to doing the minimally invasive procedure. It is the same like teaching any person to drive an automatic car or start by manual car and then look for the recent or the most advanced technology. It's going to be easier, but don't start by minimally invasive procedures before you have to address and you have to know how to do or how to perform the traditional operations properly, and then go to microsurgery or endoscopic, whatever may be, minimally invasive. And another point, in order not to be dependent too much on the technology, which sometimes you can find there is no technical support, not only because the company will stop producing these lenses or this technology, because also sometimes there is very difficult requirements for maintenance of these lenses and for this equipment. Sometimes you can discover that there's problem in the operation room while using this technology. So you have to be careful about all these points. I agree with Professor Mahmoud Qurashi. It's very important point to be addressed.
Actually, there are some questions, although some speakers have left us because it is the midnight in their countries. First, I thank Dr. Malcolm Pestonji for giving very nice, honest talk. Especially thank you for sharing the complication dural tear, and you have switched to the open surgery. But I have a question. Do you think fusion rays are less than open surgery with this technique? What do you think? Fusion rays?
Professor Mehmet, if I may just take 5 minutes to summate some things. I appreciate a lot of things which have been spoken today. I am 57 years old. I am nearing the end of my career too. I adapted to endoscopic spine surgery barely 5 years ago. For us as pioneers, it has been a difficult task because we really didn't have any teachers. It was only passion. Mahmoud sir raised a question regarding the future of endoscopy. I appreciate that because Karl Storr's instruments were not CE certified. Today they have got the CE certification, so there is no question of now them withdrawing from the market. Endoscopy is the future of spine surgery. Please let us understand that. We may be a little old. We will stick to our old methods. I feel that what WFNS needs to do is that we need to have a training program for the younger group as well as for the senior group. We need to teach, we need to learn, we need to adapt. Please understand, when I can do a fusion, when I can put in a cage with less than 50 cc blood, sometimes even lesser than that, under local anesthesia, I'm sure nobody can question what I do. I prepare the end plates, I put in the bone graft, I do everything that I'm supposed to do. Regarding what Dr. Osama said about decompression, yes, we also decompress the opposite lateral recess. We also go from pedicle to pedicle. We see all the 4 dam roots. We open up all the lateral recesses. We remove the phlegm completely. So where is it that we are not doing proper decompression? Why is it that assumed? It is completely done. Everything is done that is supposed to be done. There is no question of doing anything half. Question
yes,
is,
dear.
Just one
Yes.
second. Please let me complete. Question is,
Okay.
why did I do a fusion in a case in which the disc was badly collapsed? Because the root was totally stuck to the discal surface. There is bone above it, there's bone below it. Exiting root foramen, I have to open up. If I'm going to open up the entire foramen, if I'm going to re-explore a stuck root in an open redo surgery, I might as well go in and do a fusion. I might as well stabilize the spine, which I am destabilizing further. That is my indication for doing a fusion. All I'm trying to tell you, sir, is that please try and understand that there is just a skin and a muscle bed in between. What I do with a scope and an open instrument is what you do with a tube, is what you do openly also. Just imagine, just close your eyes and imagine that there is no skin and no muscle in between. Then we are doing the same surgery. We are doing absolutely the same surgery. There is no difference. What Mixter and Barr did in 80 years ago, we are doing it the same thing today. It's only that maybe we are using a smaller approach, smaller instruments, lesser damage. That is all, sir. Believe me, it has been a very difficult path for me to go through and learn this. I have set up an institute in India. Every month, I have about 20 to 30 doctors coming from all over India, nearby countries, learning endoscopy. I appreciate the fact that it took me maybe 3,000 cases to come up to where I have come up. But today, when I teach my students, they come up within 20 cases to that level. Within 30 cases, they reach that level because there is dedication, passion, and the fact that it is very, very easily doable. It is just the initial fear. It's like a child that is told to jump into a swimming pool and swim, he's scared on day number 1, but he's not scared on day number 10, sir.
Okay, Professor, you see,
old school, we need to change, we need to adapt, and we need to teach. There's no question of we not being relevant. We are never going to be irrelevant. We are always going to be relevant, sir. I started from the days of open laminectomy. I started from the days of Harrington. I started from the days of Steffi screws and plates. I have done everything. I've been down the entire street, sir. And I have adopted endoscopy. I'm saying something from my heart because I'm also an old man just like you all. And I'll also be shutting down my shop maybe in 4 or 5 years and the hand starts shaking. But that's fair enough. That does not push the fact that there is something which is beautiful, something which is much more beautiful in vision, less blood loss, less traumatic to the patient, sir. So there is a role for endoscopy to play, and it will remain, sir, whether we adapt to it or don't. So I feel the time has come that we all adapt. It will take a little more struggle for us old people. It has taken me, sir. I'm the oldest, I'm perhaps one of the oldest practicing, apart from Dr. Yungjinwa, I'm perhaps the oldest practicing endoscopic spine surgeon in the world today.
Dr. Malcolm, yeah, thank you a lot. We are very late on our program.
So I wish to inspire everyone.
Thank you.
Now, can I just a very little point? We agree with you, Professor. The point is that yes, you do compression, whatever endoscopy or microscopy of the nerve root. But the point is that the facet joint takes its blood supply exterior and not from below. So whatever you do, you are not treating facet joint. Thank you. No more comments.
Yeah. Thank you, Dr. Osama. Is Dr. Xu Weibing with us? He has sent a message that it is quite late there in China. Dr. Xu, are you over there? One question is from Dr. Peter Bashenov. How often do relapses happen after ULBD, unilateral approach bilateral decompression? Actually, this is he's asking the rest stenosis rate. We know from the literature, if you follow the patients long enough, you will have 20% to 30% recurrence of the stenosis, rest stenosis. But it depends on the duration of your control. But this ratio may be higher if you make a fusion surgery, especially at the adjacent level. So if you are doing just a decompression, you can get less scared about wrist stenosis. Dr. Jung has left us, so then the questions to him cannot be answered. Dr. Jung from Korea. Dr. Zhang Wai is with us.
Yes, he comes.
Yes. It was very interesting presentation, really. I understand Dr. Zhang is making first decompression of the contralateral side, then ipsilateral side. Am I right, Dr. Zhang?
I first do the ipsilateral side decompression. Then I do the contralateral side decompression.
First ipsilateral side.
After finishing the ipsilateral decompression, then I do the contralateral side.
Yeah. Well, okay. Well, what is the diameter of your working channel?
What? Pardon?
What is the diameter of your working channel?
Working channel, about 7 or 2 millimeter.
7
or 8 millimeter.
7 or 8 millimeter. Dr. Raja Shekhar is asking you, what is the advantage of third portal?
For me, the third portal is more straightforward for the contralateral decompression. And I think we can do the contralateral decompression more directly because the angle of the instrument is very good and comfortable, I think, through the contralateral side portal.
Yeah. Yeah. How is there any other way to control bleeding besides radiofrequency lesion? Another question.
There's many methods. I think the anesthesia is very important. I prefer to the general anesthesia. I ask the anesthesiast to control the bleeding pressure, especially the low systolic pressure below the 100 mHg. And I often use the bleeding control material, including the gelatin sponge and the bone wax. And you must know where is the frequent bleeding area, including the proximal insertion of the flap ligament. There are many vessels on the surface of the dura, and the isthmus. We all know the segment artery, the posterior branch. When we do the fusion procedure, we must do the bleeding control first.
Okay. There is one question which was directed to Dr. Jung, but I will ask that question to you, Dr. Harshad Parekh. How, what is the biggest advantage of endoscopic application for decompression and interbody fusion? Are the results different than microsurgery? Dr. Zhang?
You ask me?
Yeah.
What is the question?
The question is, what is the biggest advantage of endoscopic decompression and fusion in comparison to open surgery or microsurgery?
In the majority of my case, I often do the fusion case by the biportal. I think a biportal is similar to the microscopic surgery under the water media. So I think the operation view field is very clear and very big. So is a low opportunity to damage the nervous structure under so clear the operation field. And another thing is when we deal with the disc space, we can see the endoplate very clearly. So I think I can remove the majority of the disc fragment. So I think there is a very high fusion rate after the ULIF or XTLIF. And if we do the anterior and transversing the cage, I think we can restore the lordosis of the lumbar. It is introduced by the Professor Erm. I think the TLIF or ULIF procedure under the endoscopy is very good technique. Thank you.
Okay. Dr. On from Korea, do you wish to say something, Dr. On?
Oh yes, the best advantage of endoscopic surgeries, I think Professor Zhang already mentioned, is surgical view is very clear, and we can control the breathing, and that is the best thing, I think. And the ways the surgical procedure is nearly the same as minimally invasive surgery. So we can save paraspinal muscle more, and we can have good surgical view and less bleeding. And this is the advantage of endoscopic surgery, I think.
After how many cases do you feel confident with the endoscopic fusion? How many cases?
How many cases?
Do you feel confident?
Confident. I think 95% more, I think, confident. Because
after 90 cases, 100 cases, or 500 cases?
500 cases more, okay.
Okay.
So we need more, but
Good
we need
number.
more.
500 cases.
Yeah.
Good. This is probably most remarkable sentence of this panel. Yeah, thank you.
But we must collect more data still.
Yeah.
Okay, thank you.
I think we came to the end of the this seminar. If there is no much comments, we can finish it. Dr. Nasser.
Yes, I think if do anybody would like to say any more comments from the panel?
I would, if I may. Just
yes, please. Yes, please, Mahmoud. Go ahead.
Given the number of cases we've just heard that requires competency to develop, and I would imagine the views would be different. Are there any recognized red lines that you say, okay, stop doing it this way, revert to an open procedure? Is it bleeding? Is it difficulty dissecting the nerve root? Is it a tear of the dura? Is it a tear of the exiting nerve root? What are you, in your consensus view, the red lines where you say, young neurosurgeon, stop your ego, get on and open up and do it a different way? What would be your advice for those who haven't reached the 500 cases that we've just heard about, or the 100 cases or the 95 cases? What is the red line where you would say, no, change your approach, otherwise you might run into real trouble?
Can I answer?
Please,
yeah.
please.
Yeah. Actually, in the learning stages, frankly speaking, within 10 cases, or also I have to convert to the open surgery because of the severe bleeding. I can control bleeding. Some cases I can control bleeding with biportal endoscopic surgery in the learning stage. I have to convert to open surgery. And we injured the dura, and when you see the dura tear, I also convert to open surgery. But now I can do in the endoscopic dura suture, we can do it. Okay? So in the learning stages, maybe sometimes within 10 cases, maybe 50%, we have to convert to open surgery. But actually, right now, almost 90% of endoscopic surgery, just 1% we convert to open surgery. Yeah.
So it continues to improve with your learning curve.
Thank you. It's a learning curve problem.
I must tell, with the tube guided surgery, the metric system I'm using, I didn't switch to open surgery in any case. But stitching the dural rupture is not very easy. And I must tell, first 100 cases is the confident level for that type of surgery. 100 cases. After 100 cases, you feel that you can do everything under this, even some intradural tumor surgery.
Great.
Yes, I agree with you. I think, Mehmet, it is time to close the webinar. Now, I ask Professor Mehmet Zerili, Chairman of the Spine Committee of the World Federation of Neurosurgical Societies, to say if he has to say any closing remarks.
Yeah, thank you for all the speakers. There were very, very nice unbelievably nice lectures, very, very nice videos from their surgeries. Yeah, I appreciate them for their talks, but probably we must admit that there is a learning curve of such to be confident with such surgeries, and it may be different in different type of techniques, but there are significant advantages, especially the infection rate is lower. You can apply day surgeries with these techniques. You can make those surgeries under epidural anesthesia or spinal anesthesia, and even local anesthesia with sedation. So less blood loss is main advantage of those techniques. We will learn and we will be more competent by the time. Thank you for all the speakers for contributing to this very nice panel.
Thank you, Mehmet. Mahmoud Khorashi, President of CANS, would you like to say any conclusions before I close the webinar?
I'll just very quickly, on behalf of the Continental Association, once again reiterate the amazing work that goes on through these webinars. It was unbelievable before the pandemic that we could reach such level of education through online learning platforms. And it's been absolutely brilliant, but brilliant because of efforts such as yours and of people such as the panelists and the speakers that we have had. Without their thoroughness and their effort in bringing out the detail through their videos, their slides, their lectures, this would not have been possible. So on behalf of all our member societies and our young neurosurgeons on this who are participating, I'd like to say a big thank you to you all. Thank you.
Thank you very much, Mahmoud. At the end of this webinar, first of all, I would like to extend my apology for extending this webinar 1 hour and 15 minutes more. I know now it is in Japan 1:15 in the morning, and I would like to thank our Japanese colleagues and our Chinese colleagues who are joining us until now, and it's 15 minutes after midnight in China. I'd like to thank Professor Mehmet Zelili for giving us such opportunity to have such wonderful collaboration. Thanks to all our distinguished speakers. Thanks to Mahmoud Khorashi. Thanks to everybody who commented and joined the panel. Professor Andriy Huk, who is Secretary of the Ukrainian Association of Neurosurgery. Thanks to Professor Osama El-Ghandour. Thanks to all our participants. May I not forget to thank my organizing team, Mr. Ahmed Magdi and Dr. Hassan Ala, for the hard work they are doing with me in organizing this series of webinars. And I would like to emphasize that this is a WFNS event. It's recognized by the World Federation of Neurosurgical Societies, and the certificates that we are offering are approved by the World Federation of Neurosurgical Societies. Let me just remind everybody that next Friday, we canceled our webinar as a sort of coordination with another colleague who is organizing another event at the same time. Our next webinar, webinar number 51, will be held on Friday, 20 August at the same regular time from 12 to 3 p.m. GMT, and is going to be done in collaboration with the Rehabilitation and Reconstructive Committee of the World Federation of Neurosurgical Societies, Professor Virendra Sinha. Thanks to all of you for contribution, for your time, for your experience. It was a great, successful webinar, multidisciplinary, with knowledge exchange between orthopedics and neurosurgeons. Thank you very much.
Thank you. Goodbye.
Thank you.
Goodbye,
Thank you
everybody.
very much.
Bye-bye.
Thank you so much.